everyone. I am Bedelia C. Hargrove, the Chief Probate Court Judge in DeKalb County, Georgia. Welcome to DeKalb County and welcome to the DeKalb County Probate Court's 2024 Mental Health Symposium. As many of you know, this is our fourth symposium that we have hosted. We were at the Maloof in 2019. We were virtual in 2022. We were at the Porter Sanford in 2023. And here we are today at the DeKalb County Government Training Center. And I'm very excited to have you all here at this facility. It's a fairly new facility, so we're excited to try it out for this year. This is actually the first year that this symposium had two options, either in person or virtual. So we do probably have close to 100 folks patched in via webinar at this time. So we want to try to stay on schedule so that we can keep everybody else's schedule on track. As I said, we are so excited to host you here today. I want to give a very special thank you to all of my staff for their assistance in making this symposium happen. It is not easy to make something like this happen and to bring people together and get registrations correct. And so I thank my staff very much because I would never be able to accomplish this without them. As I had mentioned to you all last year, there is no better place than DeKalb County to talk about mental health. We are a high volume essential services court. And in my opinion, and it's just my opinion, but I'm allowed to have it because I'm in DeKalb, I believe that the mental health cases that we handle in DeKalb are the most prominent services that we provide to the citizens of DeKalb County and to persons found in DeKalb County. So my court takes great pride in handling the mental health cases and the high volume that we have. We actually receive involuntary commitment filings from 5 different entities. We receive them from Georgia Regional, we receive them from Emory, we receive them from Peachford, who is a habitual filer, and we also receive them from Claritel, formerly DeKalb Community Service Board. And then last but not least, we receive filings from the Atlanta VA. So here at the DeKalb County Probate Court, we like to stay in our lane and we like to perform the work of our court. Our court also has a very unique relationship with Grady, and we have 2 speakers here today from Grady. But we do have the occasion to send some of our order to apprehend subjects to Grady for mental evaluations. Every time I think of Grady, I am reminded of the service that I did for retired Fulton County Probate Court Judge Pinky Toomer when I served as a court-appointed attorney as well as hearing officer for involuntary commitment cases. I had the pleasure working with both Samantha Johnson, who's counsel for Grady, and Dr. Cotes at that time. So you could only imagine that it's so good to have them both here today. This year is also a very special year for me and the Mental Health Symposium because my Associate Judge, J. Caroline Freeman, has actually agreed to run the show this year so that I can actually observe and take all of this in. I'm sure I'll have some great suggestions for next year's symposium because we will convene again next year. Before I take my seat, I would like to acknowledge the recent passing of attorney Mark D. Welsh. Mark D. Welsh served as a court-appointed attorney and guardian ad litem for the DeKalb County Probate Court for me. He also served as court-appointed attorney and guardian ad litem for my predecessors, Judge Gerald Rosh, as well as Marion Guest. So suffice it to say, Mark D. Welsh was an institution in and of himself, and he will be greatly missed by my court and I'm sure by his colleagues. I have here this morning my esteemed commissioner, Robert Patrick, who, if you look at the flyer, you will notice that he has sponsored both the breakfast and the lunch for today. We also have another breakfast sponsor, Anthony Drummer, but I have my commissioner here at this time, and he's, as most commissioners are, he is always needing to go somewhere else. And so I am going to turn over the mic to Commissioner Robert Patrick so that he can bring you words. And then once he is done, you will next hear from my esteemed Associate Judge J. Caroline Freeman, and I will be seated over here enjoying the program just like you all are. Thank you all again very much for coming out this morning.
Well, good morning, everybody. How are you today? Well, good to hear that. Good to hear that. You know, since the pandemic, we've learned that public health, physical health, and also mental health are things that are really the great equalizers in our society. Whatever the perception people have of someone as a county commissioner, you know, I too have had an uncle that committed suicide due to mental health conditions that were prevalent at the time. It is something that is inescapable. We all have down moments, but it is something that if we work together, I think we can work to address. This is something that takes time, it takes patience. It's easy to get angry or emotional, but it's one of also those things where we have to learn to slow it down, take it easy, and sometimes that more compassionate ear and listening and a hug is what is appropriate. Certainly not necessarily all the things that happen in the courts, I understand that, but more from a family side, it does take that patience and realize that this will be always an ongoing effort, and every day is one step better, and one more reason to be grateful for those days that we have with our family members. With that, I have learned that politicians that speak briefly tend to get reelected, and I got reelected very easily. So I want to stick with that theme, and thank you very much, Judge Hargrove. Thank you for the conversation we had, I guess, several months ago on this topic. And it is, mental health is something that affects all of us in some way or another. So thank you all for being here. Good morning, and enjoy your breakfast and your lunch.
Good morning. Okay, it's my job to keep us on track, so let's get started. First, thank you, Commissioner Patrick, for being here and for sponsoring, and thank you, Judge Hargrove, for entrusting me with this job today. I will do my best. And thanks to all of you, those of you here in person and those on Zoom. We are gathered for our 4th symposium on this very important topic. Before we begin, a couple of notes to make the day go smoothly. We will have a brief question and answer period at the end of each panel. If you are participating by Zoom and have a question, please put it in chat and we will be monitoring that. If you are here and want to ask a question, please do not speak until that microphone reaches you. We want our Zoom folks to be able to hear everything that's said. Most of you may already know restrooms are out the back of this room and down both halls across from the elevators. And we are so fortunate to have our vendors. We have representatives from Claritel and NAMI up front, so please take a moment to visit their table during a break or at lunch. Okay, I think that's it. Let's get started with our first panel. Outpatient treatment, ACT teams, wraparound services, other alternative treatment solutions, and ethical considerations. The good, the bad, the ugly. The moderator for this panel is Samantha Johnson. She is Senior Associate General Counsel for Grady Health System, where she advises, counsels, and educates hospital employees and medical staff regarding the legal aspects of patient care, ethics, human resources, compliance, and regulatory matters. So please join me in welcoming Samantha Johnson and the panelists for panel number 1.
Good morning, that's loud. Good morning, everyone. Thank you so much for being here. We're really excited to present this panel today. I have some wonderful folks up here who are going to talk about the way things are, the way things are moving, the way we hope things should be. And I hope that you take some new information home with you from this panel. So at this time, I'm going to ask my panelists to introduce themselves and tell you a little bit about what they do, and then we're going to move into our panel.
Thanks so much, Sam. I'd also like to thank Judge Hargrove for the invitation to be here. My name is Dr. Robert Cotes. I am Professor of Psychiatry and Behavioral Sciences at Emory University School of Medicine. I am founder and co-director of the Clinical and Research Program for Psychosis at Grady. I served as physician expert for an initiative called SMI Advisor from 2020 to 2024, which was a federal grant administered by the American Psychiatric Association, where I co-chaired the Clozapine Center of Excellence and the Long-Acting Injectable Center of Excellence. My areas of research interest are in clozapine and early psychosis and understanding cardiometabolic side effects of antipsychotic medication. I worked on an ACT team for a little while and actually specifically helped with some clozapine patients on the ACT team. And it's great to be with you all today. Thank you.
Good morning. Good morning. I'm Sarah Harris. I'm the probate judge for Bibb County. I am also on the governor's, I call it the Governor's Commission. It's not really the Governor's Commission for Behavioral Health Reform and Innovation. I'm the chair of the Involuntary Commitment Subcommittee, and I'm also a member of the Forensic Workforce Subcommittee. I have had somehow a passion for mental health, and I look out and I was going to say I see a lot of familiar faces, but that's now a term of art, which means that's someone who's cycling through the mental health or criminal justice system that has mental health injury, mental health illness. So I do see familiar faces, but not those kind. I've been on the speaking circuit for, I think I said this is my sixth panel in 2 months, trying to educate lots of different groups on what's going on in mental health.
Good morning. I'm Melanie Bell. I am the probate judge and chief magistrate for Newton County. I want to be Sarah Harris when I grow up. And so I've only done 3 of these in the past couple months. So I'm just learning. But I have a passion for mental health cases. I was a prosecutor before I ran for office. I tend to specialize in handling those cases within our office where the defendant may have especially been having sort of their first psychotic episode and it led to a fairly violent crime, and trying to get them through the system in a way that kept society safe but also got them the help that they needed. And then I have a personal family history of issues with depression, bipolar, and suicide, so that has always sort of made me focus on mental health, the importance of mental health for the community and for the court system, and that's what drives me to be here today.
Good morning. My name is Mercedes Merle, and I am an attorney. Been practicing in Atlanta since 1990, and I started out in taking appointed cases representing patients who were being held, I should say held, because none of the patients I ever represented wanted to be in a psychiatric hospital. So I started representing a lot of those individuals, and it just over the years it has grown, and I am fortunate enough now as part of my practice to serve at the will of Judge Hargrove, and I serve as the hearing officer and hear mental health cases in DeKalb County Probate Court. And while I don't have any family members with mental health issues, I think any individual that has a concern or care for their community, this is an area that you just can't help but want to help people. And if you are that kind of person, we always love to have people volunteer as appointed attorneys for those attorneys out there that would work in this area. Thank you.
So today I want to open up asking Judges Harris and Bell to tell us a little bit more about what the current legal landscape is for mental health. For the cases that come in your courts, what kind of options are there for the patients? How is the system working now? And what changes are you seeing or do you hope to see as we go forward?
So I said that I would talk a little bit about at the local level. We have seen some improvements since the changes that came with 1013. I do feel like, especially our local law enforcement has been much better educated. They are still very unlikely to use some of the resources that are now legally at their disposal. But unfortunately, we're a county that we have about 120,000 people in our county. We're 35 miles from here, but it is a world away. There's no public transportation. We have one outpatient mental health location in the county. It's in the dead center of what is a geographically large county. So we're still trying to work to build the bridges we need to build and get the right people at the table to really utilize what I think may become available. And I continue to push for that. I know our sheriff does, because he definitely is what we see everywhere, which is, the truly the one local mental health facility in the county is unfortunately the county jail. And in my capacity as chief magistrate, I see those people every day. We do things sort of on a small level, but we're still pushing to get the right people, as I said, at the table so that we can really move forward in a stronger, more collaborative way.
So on a higher level, from the state level, there's a lot going on. And what I have learned after working so hard to get 1013 passed, we really had to step back and say, oh, wait a minute, we have a workforce deficiency, we need more money, we need more programs. There were so many things that were identified as needs for our state that it became very clear that we're not going to solve our mental health problems overnight. And it's going to take not only a village and a pile of money, but it's also going to take time. You don't build a workforce overnight. And many of our problems that we're still facing have to do with workforce and access. When you think about Georgia, 159 counties, if you live in Atlanta and the metropolitan areas, and even in a city like Macon, it's hard to imagine not being able to pick up your phone and call your community service provider, and they are able to help you. But this goes on every day across Georgia, outside of these metropolitan areas. And the metropolitan areas are then sort of suffering because they're getting not only their people, but they're getting all the surrounding communities. People are coming in. I get involuntary commitments, and I would say in the last 2 years, over 50% of them are not even Bibb County residents. They're residents from other counties. So we have a service provider issue. Don't get me wrong, the services are there, they're out there, but they're not accessible. And that's where Georgia has always been rated very low, is access to care. And sometimes it's hard to see that when you're in maybe a city that has plenty of care. Columbus is kind of a shining light, but they have a state hospital. They have the Bradley Center. They have St. Francis. They have New Horizons. They have American Works. And they're a smaller population. So it's really hard to take that and emulate it everywhere. And one of the things we found, and one of the things that the commissioner identifies, is that we can't make a one-size-fits-all in the state. It's not going to work that way. So we have to think outside of the box. And I think what we've seen is that House Bill 1013 has tried to do that, has tried to give the flexibility for communities to come together and do what works for their community. So what's happening is we're beginning to have more collaborative efforts. One of the things that I've observed, and I go and speak to different groups, talk to different people. I have judges calling me saying, what can we do here? And what I tell them and what I'm hearing is that in the areas where things are working better are the areas where communities are able to be collaborative. They are able to bring in the sheriff's department, the court system, the criminal justice system, public defenders, district attorneys, clinicians, the providers in town, and they're sitting at the table and having a discussion as opposed to pointing fingers and saying, well, I sent somebody and you didn't see them. There's more of an understanding of what's going on. We are crisis focused. We're crisis focused in the state. Someone is in a crisis, we send them to the CSU to get treatment, or we send them to the hospital to get treatment. And the goal is to get them out, get them into outpatient services and get them out. So there is an effort now to increase not just our outpatient services, we have a lot of outpatient services, but to increase the population's access to that service. And that's going to happen in different ways. We have to have transportation. We have to have supportive housing. And we have a project that's going on in at least 4 of our counties right now, and some other counties informally, called assisted outpatient treatment. The counties that are using this, that are successful, have a really good collaborative network. And I will use Columbus as an example, and I will use Thomasville, Colquitt County, and what's the other county? Thomas County. They have the same provider. So they use Georgia Pines. Georgia Pines has come together with them. They have an ACT team. They have peer support specialists. They have a sheriff's office. They've got a transportation pilot program they're just launching. They have really come together and identified what their needs are, identified how to make this work, and they're getting people in the program. So who are these people that are going in the program? The people in the program are individuals with serious mental illness. And they're people that have refused treatment, that have said, I don't want to take a medicine, or maybe they have a condition that says, I don't recognize that I have a mental illness. And they can't. They don't recognize it, and they can't recognize. And I'm gonna let you say that word, because it's anosognosia. Did I say it right? So, anosognosia, which means they don't recognize they have this illness. So you have to treat them differently. But these collaborative groups are coming together, and they're learning all these different things and understanding what each person does. I understand the crisis system so much better than I did 5 years ago. I understand how it works. And I do see improvements. I had a judge yesterday that I had kind of called out and said, hey, you've got to stop sending your OTAs to the state hospital. Let me explain why. And I went through the bed issue, and I said, okay, ideally we'd love all the state hospitals to just be able to take crisis for evaluation. But we don't have the resources to do it that way. Let's try to use the system the way they have it set up. And so he said, what do you want me to do? I said, call GCAL. If you have a problem, then you call me back. He called me back in 10 minutes, said, I was on the phone with GCAL 5 minutes. I'm sending this person to River Edge. They're already heading out to pick him up from my sheriff's office. Thanks, that worked great. That is a huge improvement, because the number of complaints we have about this is astronomical from judges. But that is an improvement, and that is the commissioner, and I may sound like I'm tooting his horn, but I really am, because he does see the problem, and he's a fixer, and he wants to try to fix the problem. And I have said to him, if you don't want people going to the state hospitals and being sent to the state hospitals, you need to tell your CSUs when we send a patient there, they got to keep them. They got to take them and evaluate them. That's what they're supposed to do. We have to make the system, if it's going to work, we got to make it work in the right way. So I think he's committed to that. He's committed to trying to keep the system on track and keeping it working. So I see a lot of these changes. They haven't all trickled down yet. You may not be seeing them yet, but these assisted outpatient treatment programs, you don't have to wait for a pilot. If in your community that's something that you think could work, you can work to get the people together at the table. There are grants out there. Georgia State is working with us right now, their Health Policy Institute. We have consultants there who are working with DBHCD and with the commission that can help you with finding grants. I finally had to do a separate folder for them because they send me grants all the time to say, hey, you got somebody who could use this grant? We've got this. This sounds like something we could do. Mental health is a hot grant topic right now. So there is money out there. I know grants aren't perfect because you got to renew them and you got to get the money every year. But there are some places like Columbus that they've got some grant money, but they're trying to use their resources with what they have. They have only hired one person for their assisted outpatient treatment program. They are trying to build from within, recognizing that grant money might not be there forever. And they're determined to keep this going. So that's kind of the big picture of what's going on statewide and what's going on internally at DBHCD.
Thank you so much for sharing that. Many folks in this room are familiar with Grady's place as a crisis center, as an emergency receiving facility, an evaluating facility, our 13th floor treatment facility. But I think most people are not as familiar with the sort of outpatient programs that we do have available. And I wanted Dr. Cotes today to talk a little bit about the characteristics of the patients that we're seeing in the outpatient clinics, and then the sort of services that are available in that space as well. And I will say, I first met Dr. Cotes when he came to Grady as an attending physician, so I have watched him grow in his practice since then, and expand the programs that are available, and I'd like him to share a little bit about that today.
Thank you so much. So I worked on the inpatient unit at Grady as the medical director from 2012 to 2018. And we had a 24-bed inpatient unit, and we saw predominantly people with serious mental illness. And like what Judge Harris was saying, so just to define it, serious mental illness is usually thought of as people with schizophrenia spectrum disorders, bipolar disorder, and major depressive disorder, severe major depressive disorder, sometimes with psychotic features. So psychosis, or a disconnection from reality, is sort of one of the features of serious mental illness. So on the inpatient unit at Grady, we saw about, I would say, 65% of our patients had some sort of schizophrenia spectrum disorder. And there's a lot of misconceptions about what schizophrenia is, which I don't have to really go over with you all here. But people with schizophrenia are much more likely to be the victims of violence than the perpetrators of violence. And, you know, people with schizophrenia have a number of challenges that the mental health system works with them on. So it's not just the reduction of psychosis symptoms, which are delusions and hallucinations. They often have difficulties in cognition, and they have negative symptoms, which means less sort of motivation, and so there's a number of different domains of symptoms that people have. So as I was working on the inpatient unit, it was clear that we needed to have more specialized programs for people with psychotic disorders. And over the years in the psychosis program, we developed a continuum of services for people with psychosis. On one hand, there are the ACT teams, which is assertive community treatment. We have 3 assertive community treatment teams at Grady. And this is the highest level of outpatient care that's sort of in the state of Georgia, and that's the gold standard evidence-based model. We're going to talk about the good, the bad, and the ugly of the ACT teams and of, I think, probably all the sort of services in general. But one of the problems is there's not enough ACT teams for all the people that need them. I think finding an ACT team, it can be quite helpful for certain kinds of people, but there's just not enough of them to go around. The other thing that we focused on a great deal is a medication called clozapine. And clozapine is the only medication that's FDA approved for treatment-resistant schizophrenia, which happens in about 25% of people with schizophrenia. And it's highly underutilized in the state of Georgia in particular, as well as the Southeast. It requires weekly blood monitoring for the first 6 months, which is a barrier for many people, understandably. So we've really focused on increasing clozapine use. And clozapine is the only medicine that actually helps to reduce suicide in people with schizophrenia, and it also helps to reduce violence as well for people with schizophrenia. So we have a robust clozapine program and work with people throughout the state around increasing clozapine use. I think the other big shift is, we heard from Judge Harris about the crisis model, and I think that there is a shift at Grady from a reactive stance to a more proactive stance around the prevention and treatment of people with psychosis. So we have an early psychosis program called Project Arrow, which is one of 10 programs that's been developed by DBHDD through a grant mechanism, the Mental Health Block Grant. So there's 10 of these programs, and it's basically like an ACT team for people with early psychosis. So I think one of the things that you could do is if you see someone with early psychosis, please try to refer them to a coordinated specialty care team or a first episode team is another way to think about it. They're called the Georgia Light programs. Because, first episode psychosis is typically defined as the first 2 years that people have experienced psychosis. And if you can intervene then, you may be able to play a role in making sure that people don't have to go to an ACT team or getting involved with the legal system more broadly. And then the next thing that we've been developing has been a focus on what's called clinical high risk for psychosis, or even before people develop an episode of psychosis, trying to intervene there and educate people. There is people may have briefer, attenuated symptoms of psychosis, and finding these people and providing them education about what this is and then being able to follow them may play a role in helping to reduce the duration of untreated psychosis, which is a key variable in the long-term outcome. So I would say that our outpatient programs are really sort of geared at a continuum for people with serious mental illness. We have, those are the programs that I run, but we also have a specialized bipolar disorder clinic. And so I think that's sort of an overview of kind of where we are with outpatient services. Grady?
Okay. And what programs do you think are showing the most promise of keeping people from cycling through the system and becoming the familiar faces, as Judge Harris put it?
I think that, one of the key themes is the coordination, because we in DeKalb County and in many other counties have a very fragmented system. There's a fragmented system from the inpatient side, from the outpatient side, to the forensic side, and that and I think one of the challenges is there's There's 10 inpatient facilities where people could go. There's the state hospital system. There's just a lot of places where people can wind up. And a lot of times those places don't necessarily coordinate with each other. So in places like the Georgia Psychiatric Physicians Association, we're really encouraging our providers across the state to really focus on just talking to each other, picking up the phone and talking with each other. And there's challenges with that. I think part of it's related to the workforce issues. There's turnover at places and there's institutional knowledge that's lost. But that coordination, I think, would be the first part of the answer to your question. And sometimes that, I know I did my training in the Northeast where we had a relatively small town and people knew each other and it was easy to kind of reach out. But in the metro Atlanta area, there's a lot of different places where people could go. And then sometimes people go further than that. So I think that the sort of interventions that show the most promise are the assertive community treatment teams. There is a version of assertive community treatment called forensic assertive community treatment, or FACT teams. AOT, which we have the pilots. Early psychosis programs or coordinated specialty care, I think, are another really great way in early psychosis to help prevent the cycling through. There is intensive case management, which actually has pretty good data. And intensive case management is a level of care that's before an ACT team, where the case management team usually visits the individual 3 times a week or so. And then there's some other innovative models, I think, occurring across the country. We have some colleagues in New York who have been part of this new intervention called extended care units in Manhattan, and they are able to keep people there for maybe 180 days or so. So it's sort of an intermediary between these sort of short stay hospitalizations on the inpatient and then the longer term stays in the state hospital. And they use a recovery oriented framework, and they have I think it's an innovative model that they have in maybe 6 different hospitals in New York.
Mercedes, I'm going to toss this next question to you, serving as both a hearing officer and as an attorney who's represented patients in these settings before. Can you talk a little bit about some of the programs that you've seen that you feel have been helpful in changing the cycling of inpatient admissions?
Let me first start. In our court in DeKalb County, we have quite a few petitions that are filed where people seek hospitals of the 5 that Judge Hargrove recommended or referred that we take cases from, and they file what everyone knows is a 1021 or a petition to keep someone in the hospital. Typically, they wouldn't agree with that. So, but they ask for an inpatient followed by an outpatient, because the code sections right now, mental health, keeping people in hospital, is kind of a code-driven procedure, and it works with the doctors, because people come to the courts, ask for these commitments, either inpatient followed by an outpatient, and I hear them, the judges hear, the other judges hear them across the state, and they commit people to hospitals. And then the doctors, at some point, no matter what we might say, feels like they no longer meet those criteria that we committed them to, and they discharge them. And so that may be a good thing or a bad thing, because the families in the community that are associated with these people think, okay, whew, I've got my relative committed to a hospital for the next 6 months. I don't have to deal with them. But, that's not how it works. So that may be sort of some of the bad things that you're talking about. But before I address those further, I'm going to go back to what I see in terms of outpatient. A lot of times we see the inpatients followed by the outpatients. the outpatient code section requires when they submit that petition asking for an inpatient followed by an outpatient, they have to have a plan attached to the petition at that time. It's not like you can come back and, oh yeah, let's that would be a good idea in the middle of the hearing. Maybe we should commit them to an outpatient now. No, that plan has to be provided, which means that under the code, a doctor has to recommend and agree with those plans. And that plan is typically a plan that's going to keep them from predictably coming back to the hospital once they're discharged on that plan. That plan also requires that there are, as Judge Harris said, that there are services in the community, because you can say that's a good plan, but if there are no services out there for them, or you don't have anybody that's going to provide those services, you can't commit them to a plan that doesn't exist. So that is something, what we see is typically is the way the code works is they can be committed up to 6 months in the hospital. And it doesn't always make sense to, and the code also says if you commit them to 6 months and you have an outpatient you want to commit them to, and you commit them to at the same time, 6 months in with up to a year in the outpatient in the community. That year starts to run from the day we have them in the hospital. And if they spend 4 months in the hospital before they're actually discharged into the community, the first 4 months of their year order to remain under that plan in the community has been eaten up while they're in the hospital. So typically, from what I've seen, most hospitals won't even put forward an outpatient commitment plan until that person's closer to being ready to be discharged. And this is a place where you have good social workers. If you have good social workers in your hospital and they know all the ACT teams in the Atlanta area, we have access to ACT teams. And the ACT team may have worked with them before in the community, and they said, we need just that little extra push. We need a court order to make them do something. Or their family is insisting that, you know, we need a court order to make sure that they follow through with that plan. Then the hospital and the community and the social workers will all get together, develop a plan, file it with the court before they're ready to be discharged. Then the probate court in here in the metro area, either Fulton, DeKalb, will have a hearing with, usually they set those within 10 days, and it has to be heard within 7 to 12. If it's just an outpatient, they're running on a little different schedule. We have a little more time to have the actual hearing. And so that's kind of how they work in terms of getting that order to get someone committed in the hearing. And I just wanted to mention what is really important in terms of if you're representing a patient that they're considering to have an outpatient commitment for them, make sure it's something they can do. We talk about these plans extensively during our hearings. If you want someone if you want a court to order someone to be available, go see a doctor once a month, check in with their outpatient provider. You need to make sure they can get there. Or how are they going to get there? You have to make sure that, you know, the person who is hearing that case understands that they can hear from the patient that they will agree to do that. Because a lot of times you can come up with great plans, but if the patient doesn't want to do it, you know, they're not going to do it, and then you're bringing them right back to the hospital, and what has that accomplished? So you need to hear from the patient. So if you're an attorney representing someone, you have a duty to talk with them ahead of time, go over that plan, find out, do they have problems with that outpatient plan? Because a lot of times, you know, they do have problems, and you need to say, what is your problem? And most of the patients, because by the time they're ready for an outpatient commitment plan, they have been you know, stabilized by the doctors. The doctors think they're ready to be discharged, and they will tell you, well, I really don't want to do that because I want to work. Well, does their plan have a provision to help them get access to, you know, maybe job training while they're trying to, you know, while they're keeping up with their medications that will allow them to do what they want to do? So I'm sort of gonna stop right here and kind of flip on the other side. what I see in private practice is I have families come to me all the time and say, I want to seek a guardianship for a relative or a family member in the community because they won't get treatment. And I really just want to know what's going on and how I can help them. So what we want, we're one of the fortunate states that we have recently, in 22, I believe, had advanced healthcare, psychiatric mental health care directives, where a person might sit down with their family and or they can sit down with someone and fill out a directive that says, these are the symptoms I know I have crisis, and if I'm in crisis, here's what I want you to do for me. Here's the drugs I don't want to take. Here's the drugs I might take, and write out what would you like? Because in Georgia we have bodily autonomy. People can say what medications they want to take or don't want to take. And then only if a doctor finds it's necessary to force medications on someone would they even force those medications on them. So in an effort, what I think in terms of looking at in the community of doing more community things, if someone's trying to get guardianship over your client, you might try to see if you can have them sign an advanced psychiatric healthcare directive, advanced directive, so that they will not have to have a guardianship, because guardianship is more restrictive. It takes away more of their rights. And we want people with mental health issues to maintain as much say as they can in their treatment and care. So I see it in private practice, I see that, and you try to come up with alternatives. I think our panel later is going to talk about maybe some of the more creative ways in terms of offering treatment to people with mental health issues. But in terms of our ACT teams, when the doctors talked about our ACT teams, I hear people and talk to my clients when I had clients that the ACT team, they are involved with not only they have a social worker, they have a doctor in the community, they have a peer support leader, they have drug and alcohol counseling if they need that. They also have a team of about 7 individuals in an ACT team, which is very similar to what Judge Harris was talking about that they're trying to do with the community providers where they don't have big ACT teams like we have here in some in the metro area. But I guess the good, the bad, and the ugly, the bad is you can't, when I was saying you can't make someone participate in an ACT team, one of the ways I see that you can make them is in our mental health courts, and they are convicted or they are charged with a crime, and it's a condition of getting through the mental health court, or a condition of probation is that you follow up with your mental health providers in the community. And that may be, those are ways that you can help people with probation to help them get the services that they need. Does that sort of answer some of your questions? Mm-hmm. Or does that just make more questions for us?
Well, go ahead, Dr. Coates, Judge Harris.
I just want to add to that I think it's really important, and we probably don't consider this for the judges and lawyers in the room. Peer support specialists are people who have been there before. They've walked the road of mental illness, substance abuse, and they've been certified and trained to be a support system. And I know NAMI is here, and they've put lots of money into training these individuals and giving them a career, but they are very, very important to the system because they help bring a voice to many of these individuals. And what I've found is I sit on these hearings sometimes, and judges and the lawyers, we're in a unique role sometimes. We get to talk to the families. And the patient may be saying to the clinicians and the doctors, don't talk to my family. I do not give you permission to talk to my family. We get to do that. So we are often in a position, especially when we're having these hearings, to be able to bring out information that the providers may not know, the social worker may not know, the discharge planner. We'll often have the family member representatives at the hearing. And we'll sit in the hearing and all of a sudden we get, oh, wow, well, okay, that sort of changes things a little bit. And we'll find out, to your point, we'll also find out, oh, did y'all know that he was at Anchor or at Grady? No, nobody knew that. But they do now because they were at the hearing. So I feel like it is part of our role from the bench, and as the attorneys maybe representing the hospital or representing your patient, you may not be able to tell or talk to the family, but maybe your client will give you permission to do that. And you can get a lot of information and share a lot of information that is critical to success, for the continued success, especially with outpatient treatment, because you've got to have the supports to have successful outpatient treatment.
And so for clinicians, Dr. Cotes, as you are dealing with patients in these sort of early episodes, how do you ensure that the patients try to work with you on what their support systems might be, or what can you do as a clinician to try to get folks to be more, I hate to use this word, compliant with their programs?
Yeah, I think, part of it is in the outpatient setting, and also in sort of mental health overall. We're very interested in the recovery model for moving forward, and I think that what the recovery model is that people with mental health issues have the same goals that everybody else does, and what we're trying to do is help people accomplish those goals, getting back to work, having meaningful relationships, and really where treatment comes in is helping people overcome the barriers that they've encountered to do those things that they want to do. It's different than saying, okay, the goal here is that we're going to treat you with a medicine that's going to help the voices. Sometimes that's not what that person's goal is. We're much more focused on helping people move forward in their lives and do the things that they want to do. That is often a more successful strategy in engaging someone than focusing on the symptoms. And I think that I think that also everyone wants to avoid the hospital. I mean, partnering around avoiding the hospital is another, I think, common thing that we see. In the early psychosis space, engagement of the family is so very important. When we see a new person in our program, the standard is that the family and anybody else wants to be there is part of that team. And I think the advantage sometimes in early psychosis work is that the families are still very much a part of that person's orbit, and unfortunately later on sometimes there's fractures in the family or people get sort of disconnected from them. But in early psychosis, people are often sort of still with their families, and many times families are kind of at their wits' end, but really we're trying to preserve that. And we have a number of specific family interventions that we've developed that we've borrowed from a model called open dialogue. And in this model, we have sort of used the existing first episode model and then fused it with open dialogue, which is a way to really engage the family and keep them involved.
And Mercedes, I'm going to ask you this first and toss this to the judges as well, but as a hearing officer, how often are you seeing people come in with requests for folks to be committed to outpatient treatment? And when you talk about the detail of the plans, how detailed are these plans being made?
Well, I don't turn this one. By the time they get to us, they've already had a plan established. A lot of times the families are communicating to the social workers that they would like one, but normally they don't go and develop plans for people and has to have them committed unless they've been in the hospital at least 3 or 4 times. That where they're in the hospital, they discharge them, and they're back within 30 days or 60 days. And then they treat them again, they send them back out, they can't comply, they're back in the hospital. So there is like an amount of time that the doctors and the community people would want to see people come and go before you would just automatically put together a plan that has all this wraparound support. There are, like as Dr. Cortez says, there are some initial plans where they try to catch people, but by the time you come and you're in the court system and you're asking the court to do a plan, these people are pretty familiar with the plan. The family is at their wits' end usually. The plans are very specific. Like we talk about, well, we talk about how many times a month are they going to have to do this? How many times a week are they going to have to make themselves available so that the community provider can come find them? We do a lot of hearings with Avita and their ACT program, and that's out of like the Gwinnett area, kind of catch basin that's coming down when they're at Georgia Regional. And we see the plans are like, well, you know, they've got all these things and they're living, say, for example, with their mother, and or they're living on their own in a house trailer, and they don't drive, there's no public transportation. As hearing officers, you want to hear from the family or from the community, how are they going to get to where you need them to be? Because the way the order's structured, and we usually attach the plan with the order, so that they're clear, they know what is expected of them, all right? Because it doesn't, like I said, if they don't comply, part of the order is that where they're found, whatever county they're in or the county that issued the order, they can go and get the sheriffs to pick them up and bring them back to the hospital. And most people that don't want to be in the hospital are going to follow that plan. And the goal is if you do it long enough and you get them stable, then they can stay out longer without having to come back to the hospital. And so the plans are very specific. They discuss, you know, how, because we can say you have to be available 5 days a week to the providers to meet you at your house, at your address, okay? I can't, if you only order them to be there 2 days, they didn't violate any order if you want them to be there 7 days. So you can always not require them to be there 7 days a week. But we talk about those plans really, they take a long time to do a hearing like that. They talk about the peer specialist. They talk about all the things that are available to the person. The family usually testifies that, you know, they think that's going to be beneficial or not beneficial. What have been their problems? What are their triggers? How do we fix those if we can? So yes, it's very specific, those hearings.
And how often, as judges, are you even presented with these particular requests for orders? How often do your hearings include these components of outpatient treatment?
From my perspective, not very often. Typically what the families are coming to my office with are either a request for an OTA or a request for, you know, we want to come in and file a petition for an adult guardianship. You know, you're always very careful when, you know, my chief clerk deals with them of not giving legal advice, but of saying, she'll kind of say, what are you hoping to get out of this? Well, we want to be able to put them in the hospital. Okay, well, that's not what this is going to be. So, but what I would say that kind of dovetails into both of those is having been a part, when I was a prosecutor on the team in the mental health court, what I think that can really help us in this outpatient arena is not only educating the patient about their illness, but also the families that we see, because in my county for a long time, an OTA was the solution prior to me coming into office. And so we still have a lot of families that 8 years on are still coming in. And when I speak to those families myself to explain why I can't sign an order, I find people who are just uneducated about mental health. And so what we have taken to doing is referring them to NAMI, referring them to other resources in the community to try and get the family educated as to how they can better be an advocate for the patient or the individual who is experiencing a mental health episode. And so because of that, we're kind of almost in the education field ourselves and trying to push people to those resources. And I do think that that is a benefit I saw when I was on a mental health court team as the prosecutor was you saw the individuals, the participants in the program learning, but you also saw their families because they're seeing the supervision officers that come out to the home and do random checks. They're kind of in the program themselves, and I think a lot of times that's what's missing is that component.
You know, I will sort of add or modify. I see them coming from the hospital. So we have a geri psych unit, and we have a regular adult. Mostly the geri psych is the one that I get them from. And they just kind of as a rule throw in outpatient treatment. I often look at them and roll my eyes and say, no, that's not going to work. We know it's not going to work because a lot of these geri psych have other components like dementia and things that are going along with it. But I would say the plans that I see are a little less structured intentionally in order to leave room for flexibility within the plan. So plans can change. It is a fluid document. It's not intended to be, this is what we're going to do for the next year and this is going to work. We have to have some flexibility in it. So I always put in my order that I put language that says, you know, follow this plan or as amended by the treatment team or physicians, whatever the appropriate language is. I put that flexibility in there in order to give everyone, including, and most importantly, the individual who's under the treatment plan, I think, and correct me if I'm wrong, but I think that the movement is really to try to give the patients as much stake and thought and input into these plans as they possibly can. It's reasonable, obviously, but for a plan to work, they have to buy into it. You know, they've got to say, I'm going to comply with this plan. Or maybe they don't say it quite at the beginning, but ultimately that's what we want, because we want them to be in this recovery phase and we want them to just be routine. And what I do, and this is sort of the AOT model and mental health court model, is I will set a report back hearing. I'll say, okay, we're going to come back depending on the patient. We might come back in 30 days or we might come back in 60 days to see how they're doing, because sometimes I've had patients that we set up during COVID. We had to set up the Zoom conference so that the ACT team would go to their house, and every 30 days, the day before she was supposed to get her shot, we had a little conference with her attorney and me and the hospital attorney for me to say, hey, what are you going to do tomorrow? And she'd say, do I have to go get my shot? And I'd say, I really need you to go get your shot. She'd say, okay. We did this for 4 months till finally she just decided, well, maybe I'm going to go get my shot this month. And we skipped a month to see how she would do. And as long as she was doing it, she didn't have to have this Zoom hearing with the judge to say, and I didn't have to put my robe on for the Zoom hearing just to tell her that she had to go get her shot. So sometimes it's just that simple. Sometimes it's a lot more complicated, but sometimes it's figuring out what works for this patient. It's so individualized. It's very individualized. And so I take kind of, I don't have as many cases, I'm sure, as DeKalb, so I can be a little more flexible in this. But that's how this assisted outpatient treatment, that's how that model works, is to give the patient or the individual some independence in working with the plan and figuring out what works for them. We may not ever educate them as to what their mental illness is. They may spend their entire life saying, I don't have a mental illness, but I feel better when I do these things, whether it's taking medication, whether it's going to clinic, whatever it is. So I try to remember this as I'm working with these cases and trying to develop what's going to happen. And it is time consuming. It really is for everyone.
And I was going to say, we don't normally, because of the through the probate court, we don't go back and monitor them unless they come back through the system again and they are in an inpatient type setting again and meet criteria for inpatient settings. So like we do this is the most restrictive, and we leave it to the providers to work with the patient. Like you said, they can always do less. But the patient knows this is what's going to get me in trouble if they want me to do this.
Yeah, Judge Harris, I'm glad that you mentioned the injection, and I suspect that you're talking about a long-acting injectable antipsychotic medication. I wonder if you all could comment on a little bit more specifically about how medication gets incorporated into these plans, and it's highly individualized, certainly from the clinical standpoint, but from your all standpoint, how does that go? What works, what doesn't work, sort of in terms of how medicine is included in those plans?
Well, that's a loaded question. It depends on who you talk to. But there are some judges who feel that they can include mandating injections. I think we have kind of reached a point where we agree that we have to make some findings to be able to do that, and those findings have to be that this person is not able to consent to treatment. So those findings have to be in our order, and that you have to, my belief is I have to have a hearing, I have to have evidence, and I have to be able to say that person is not competent to make this decision. And I depend on the medical staff to provide that information to me. Some judges just will not do it at all. Some will do it just generally. So I think that due process has to be followed. There's a Supreme Court case that says in order to force medications, you have to have a finding that the person is not does not have the capacity to consent to medical treatment. So I will put in my order that they are to comply, including taking their medications or whatever it is. I put that general language in the order, but I don't specifically say you have to have an injection or long-acting medication or whatever it is. I also try in my hearings, I had one recently where the individual, he repeated over and over, I'd seen him several times, we'd had several OTAs, and we were in a hearing, and I said, they were talking about a long-acting injectable, and I said, have you ever had a long-acting injectable? Because I had asked if that was something that was available. And he said, no, I don't want one. And I said, well, tell me why you don't want it. And he said, I'm afraid it's going to hurt, which it is. It is going to hurt because it's intermuscular. Is that right? Am I saying that correctly? It is going to hurt. But the treatment team, the nurse practitioner was sitting there and she was like, oh my gosh. She just sort of fell back in her chair and she said, you know, we can work with that. We can work with that. And I followed up later because I was curious what they did. And they did a numbing something. He took it and it was like, everybody was like, well, that's a miracle. I'm like, it's not a miracle, it's asking the right questions. So that's a long answer to your question.
Well, speaking to that, what kind of safeguards would you as judges like to see in place if hospitals or attorneys for the patients are seeking these outpatient orders? Obviously in guardianships, you know, there's reporting that has to be filed, that sort of thing. And Judge Harris, you mentioned that monthly check-in with the one patient. What kind of safeguards would you like to see to ensure not only compliance with the order, but that the treatment team is doing what they're supposed to do?
So 2 things. First, let me clarify. To have an outpatient order, we either have to have a petition from the hospital or in most cases from the CSB. So we have to have a provider. And to get any outpatient treatment in the state of Georgia, it is going to be initiated from one of those 2 places. So it's either coming from the hospital or it has to come from the community service provider because they're the ones that are doing the treatment, they're the clinicians, they're the ones, the onus is on them. So for outpatient treatment that is mandated through the courts, that's how it has to work. So going to your second question, I think, this is my personal opinion, and this is from I sit in on the AOT meetings with all of the providers in the state, with the clinicians, the judges, everybody. And what I am hearing and what I think is happening is that because they meet and have these follow-ups, so at 30 days they set a hearing and they may have several. So say we have 5 people in the program. Well, we may have those 5 people coming in again in 30 days, or maybe only 4 of them. But when they come, you have the whole team there. So everybody's held accountable. You've got somebody from your ACT team. You've got a case manager. You may have a peer support. Often the peer support person is there. And they're a key link. You know what's going on. So as the judge, and again, there's a whole controversy about whether or not there's real teeth in assisted outpatient treatment or mandated outpatient treatment, but the black robe effect is real. I mean, it just is. It's real. And when they think the judge is going to ask them, so what did you do about this? You know, if you had this problem, if the person couldn't get to an appointment, well, did you ask them why they didn't get to the appointment? What steps did you take to try to get them there? Those sort of things come out in those follow-up hearings that you can do. So again, it is more work. It is a lot more work, but that is how the accountability works. When you have that collaborative effort, you're bringing it's not a solo practice. It's not the CSB is running the show or the ACT team alone is running the show. It's everybody making this work together.
And dovetailing off of that, I think that gives, I agree completely that the black robe effect is very real, but also I think a lot of times the participants or the patient feel more heard because someone is not just asking them. It's not just, why didn't you do this? Why aren't you doing it? It's, well, what did we do to try to deal with that too? Because, you know, I think sometimes people, whether it is their actual illness or just history with the system, they feel very much like everyone's against them. And so they can feel like, well, this person is looking out for me also. They see that I'm, they get told a lot, not necessarily from their providers, but from the outside world. And I think feeling like you have someone who cares that is in a black robe kind of empowers them and makes them want to be a better participant or a more sort of willing participant in their treatment programs.
And I would say, as an attorney representing that person, you have an ethical duty to talk to them and try to understand their point of view and allow them to, wherever they are in their process of treatment, to express how they feel if they want to. Let them express we're talking more about the outpatient part of it, but if they were being, they wanted to, a petition had been filed to keep them inpatient, they certainly are not going to hurt themselves expressing, their opinion as to what they want, why they don't think they need to be there. They need to express that. It does empower them. I hear all the time when I was an attorney, just representing patients, I would start asking my client questions, and the client would start talking, and everybody's like, they talk. And I'm like, you have to ask them the right questions. Yes, they do. Where they may have sat in the hospital for 10 days and never said a word to anyone. So it made it difficult to treat that person or help that person because they didn't say anything. But once they start talking, then it becomes more obvious, and it's empowering. And I think that's something you always have to remember, is these are individuals, they're people, they're just like you or I. And I always use the analogy, it's like, really like someone who has diabetes or something. They don't acknowledge it sometimes. Doesn't matter if I eat all this candy and stuff. Who cares, So you have to help them. A lot of times when you have a client, you have to empathize with them and help them understand that I understand that you have an issue, but it's not any different than any other medical issue I might have. Let's figure out how to help you get treatment. And but encourage people to speak and take as much as they can. Dr. Cortez says, clozapine's like the gold standard, but it requires weekly blood draws. And a lot of people are like, I'm scared of a needle. I don't want my blood taken. And that's the kind of medication, from everything that I've read or been understood, and Dr. Cortez will correct me if I'm wrong, if they start that treatment and then they stop somewhere, it's not like you can just in 3 weeks pick up again. You have to go back to the beginning and start that whole 6 months over again before you can get less and less blood draws. Is that correct? And that's part of with the FDA distribution of the medicines and things. Is that correct?
That is correct, yes.
So.
Well, that is a great segue into the question that I have to go down the line for each of you. What steps should we be taking to ensure that patients' rights are protected while we're exploring these new and potentially innovative outpatient or even inpatient treatment options for them? And Dr. Cortez, I'll start with you.
Well, I think on a broader level, conversations like this are really important in doing that. And then I think that as an outpatient, formerly inpatient psychiatrist, and someone who's involved in education a lot, really, it's very important that we, go into situations without a conclusion, and we really take an open mind about how to sort of figure out some of these challenges. And sometimes I think when clinicians make assumptions about what might be helpful, they sometimes stop asking the right questions and things. I think that using the shared decision-making idea is really very important from the clinical standpoint. I've been in a lot of 1021 hearings over my career, and it's often interesting me to the amount of therapeutic benefit that they may actually have sometimes, just sort of getting all of those voices out in the open and hearing from the family. And it's often much more helpful to the patient than I would have initially assumed. So I think the more I've been doing this, the more I understand about schizophrenia, the less, maybe the more questions I have about it and the less that I know about it. And I think another idea about this is that, really respecting all the expertise sort of across these different disciplines and domains, and also, sort of reminding ourselves that the patient is also an expert in their own experience.
I would agree with all that. I guess from our perspective as judges, hearing officers, attorneys, of course, making sure the individual has their due process rights protected. So one of the misconceptions that we really dealt with 1013 was there were people who thought that we were trying to do these outpatient treatment without an attorney and nobody was representing the patient or the individual, and which is completely wrong. Every person that goes through my court, even if they say they don't want an attorney, get an attorney appointed. So I feel like that's the most important thing I can do. The second most important thing is to make sure that the attorney that is being appointed knows what they're doing and does their job well. And I can tell you that the attorneys in my area who are appointed for these cases know that they are not to come into court and roll over and say, oh yeah, sign the order, you're good. They know, I don't care how black and white it may look, they know they better put up whatever they need to put up for their client's protection. And I have denied involuntary commitments before. I had one very zealous attorney who came in and he did a great job, and the hospital did not present their case. They didn't put up the evidence, and I was like, I'm sorry, but that's what we had to do. So I feel like protecting that's the most important role I think I have, is protecting that person's rights and making sure that they are represented.
I was going to say the same thing about the attorneys, because I feel like, in counties like DeKalb and Fulton and some of the bigger metro counties, you have experienced attorneys that truly understand what their role is. When you get out to even just my area of the state, I'm kind of having to, even just in an adult guardianship situation, I'm kind of having to say, wait. You don't represent what's best for, the best interest. What does your client want? And I think the same thing. And as judges having to, kind of step back and say, this may not be the attorney we want to use on these cases anymore. And then something I've just been truly trying to work on that I think everybody can work on, and I've learned it from my niece who works in the special needs community, is the person first centered way of speaking to people and speaking about people, that these are people who are having a mental health issue. They are not, this is someone with schizophrenia, not a schizophrenic person, because we don't do that with physical illnesses. You're not, it's not your heart disease or your cancer diagnosis that's the first thing we talk about. It's your personhood. And a lot of times, because of the institutionalization of this whole system, we lose sight of their personhood.
And I was going to say, when I first started doing these in 1990, the only way you could see your patient or your client who was a patient was to go there, and they would actually let you on a floor where you could go in and you're among everybody that's there, and everybody wanted to talk to you. You needed to talk to your client, but everybody else wanted to talk to you too. And then hospitals kind of got that, well, oh no, we might be violating other patients' rights by allowing an attorney on the floor, because you might see someone you knew who was there that didn't want anyone to know they were there. So they no longer let attorneys go onto the floor. So then you would have to go to the hospital and have someone bring the patient from where they were to a place where they could meet with you and talk to them in advance. Now that we have the wonderful thing of Zoom, a lot of times you can call a social worker in advance, and the social worker will make arrangements to have the patient talk to you via Zoom. So there's no excuse ever for any attorney who's representing someone with a mental health issue not to try to communicate with them, not to try to explain. And as you do these long enough, if it's an in-person and you're sitting next to someone, your client, who has a mental health issue, you have to watch verbal cues to know if someone in the room is upsetting them or punching one of their triggers. Because I've been in hearings where occasionally you may have a client who and if you're watching them, you're talking and you're asking them questions, but you might kind of be rolling back a little bit going, okay, and giving them that room, because I've been in hearings where the patient, got upset. This was a patient, we're doing a hearing, he got upset, and he turned around and grabbed a person who worked at the hospital and grabbed him from behind and threw them over the table into the floor, and about 7 deputies had to just control the situation, because this person, when they came up, one person had lost a lot of their hair. And the judge said, "Do you need a moment with your client?" Went outside with my client, and he said, "I told you I wanted to go back to the jail. I didn't want to stay in the hospital any longer." And that was his whole reason he did that. It had nothing to do with his mental health issues. He just wanted to go back to jail versus being a patient in a psychiatric hospital. So, you need to talk to your clients, know what the clues are, what are the signs, what are the triggers, and help them make their presentation to the court to say, he doesn't want to be here. He would rather receive his treatment at a jail as opposed to the hospital. So, and I guess the point of that story is, talk to your client, see what they want, and that most of them will tell you.
And I would add to that, don't hesitate to tell the court or tell a bailiff or someone. We did a presentation, a couple of us did a presentation recently talking to, I think it was the accountability courts, and then we presented to GACTL, and we talked about in those sessions clues, identify some clues. Walk into your courtroom. If you're a judge, walk into your courtroom and look around your courtroom and see, are there things that might be a trigger or might be a uniformed officer. You might not can avoid that, but you might can limit that. There are different things, and if you have a clue, if the lawyer says, hey, might be a good idea to have the deputies maybe sit in the back of the rooms or, try to have a lower profile, you can work around that. We can accommodate a lot of that. I often do my hearings at the hospital because it's easier. It's easier for me to travel to them than for the hospital to come to me and bring the patient with them. So they have a nice room set up that we can use, and I don't even have to take a deputy with me. I use their staff and the police force at the hospital. But I do that to help the individual feel more comfortable in the hearings. Now, some of them it may not matter. We had one woman that escaped from the hospital because she had a hearing in the probate court, and everybody was looking for her, and nobody wanted to tell me that she had escaped from the hospital, but she showed up at the probate court because she knew she had a hearing there. and she had to go to the place where her clothes were kept at this church where she kept her shopping cart, and she wanted to change clothes, so she left the hospital knowing she had a hearing. Anyway, just an aside, but we're trying to train, my point in this too is that we're trying to train attorneys and judges to be cognizant of those things going on in the courtroom and to be observant, using the right type of language when you're talking to someone, I mean, you don't use the word crazy. You don't use, I mean, just some things that you think are common sense that sometimes I want to go, really? Did they say that? But those things are very important.
Well, thank y'all. Before we get to our Q&A, I want to give each of you a chance to give a final thought to the audience, and then we're going to open it up for questions. Whoever wants to start.
I'll throw out there for, again, the non-metro people that may be here or watching. I think we just have to continue to sort of be the leaders, and if you're in a position to kind of like start bringing people together, not losing heart in that, and, you know, doing the hard work to bring the right people to the table so we can start figuring out how we can get people resources in our communities where there's not good transportation or things like that. And finding the people in your area that see it the way you do, and kind of slowly pulling other people that maybe don't want to be part of it, but you're going to need them, you know, pulling them in. And so that's what I would like to see more of.
I don't really have any extra comments. I would say thank you to, like Judge Hargrove, people who have a vested interest in mental health. It's a thing that everyone has to work on. If you don't want to be involved in it in the court system and you have personal friends, I would say personal experiences with mental health, reach out to your state representatives or local people and you know, help get those funds available to people in the community, because it is a type of illness that it takes a lot of work. A lot of people to help wrap around services, and they're expensive in the community. So.
Yeah, and I guess as a few final thoughts, I would say that I think that the system really is very fragmented, particularly in larger areas, and it's really the collaborative effort of bringing people together that's gonna make it work. And it's hard, I think, not to end on an optimistic note, because I think that we all have seen people who we think have been in really pretty dire situations who have gotten better. And it's not really up for us to decide, you know, it's not up for us to decide or assume who's going to get better. But I think that having a message of hope and optimism is really, really important in all of this. And seeing people get better, I think, is one of the most meaningful aspects. And sometimes it really is this system and us all coming together that helps to facilitate that.
Yeah, I would agree with that. I'm very positive about the future of our programming and what we're offering in the state of Georgia. It is complicated. I'm not going to lie. It is very complicated. But we currently have a commissioner who is very engaged in improving access to care, innovative programs, really trying to think outside of the box. I will echo, your legislator is the most important person for mental health. There will be a number of initiatives, I think, coming into being proposed this year, not the least of which will be funding. We always need funding. We always need more money. But we proved with 1013 that we have very loud voices in the mental health world, and that our legislators listened, and there are a lot of them out there that have been there for several years, and they are committed to mental health. One of your representatives, Representative Oliver, she has been one of the team leaders in promoting 1013, sponsoring 1013, getting it passed on a bipartisan level. Representative Todd Jones, Senator Kennedy, who's my senator has been very active in trying to really push mental health reform. It takes a village, and it takes a lot of collaboration, and that's really the key. So I would encourage all of you, if you know your representative, if you don't know your representative, know them, reach out to them, tell them how important this issue is. I didn't know I was going to become a politician.
Thank y'all so much. We're going to open it up to audience questions. And please wait for the microphone to come around so the folks on Zoom can hear you. Okay, we got one over there.
Thank you. Excuse me. Thank you all very much. My name is Don Anderson. I'm from the Tucker First Methodist Church, which is here in DeKalb County, and we operate both a cold weather shelter and also a shelter that provides services for unhoused people in the Tucker area. We have about 50 to 55 people that we see every week. We've seen them throughout this year. The cold weather shelter's been going for several years. And of this population of 50 to 55 people, certainly a large percentage have mental health issues. And the question, I think this may be more for Ms. Morrell and maybe Dr. Cotes, how can we direct or refer these people to non-judicial mental health services that can help them reach the goals that Dr. Cotes mentioned, which are perhaps regaining employment, reestablishing family relationships? How would we get them in touch with ACTS teams? Do we go to Claritel? Any suggestions you all have would be appreciated.
I know there are services out there. I just can't tell you all of them right now. I will get your number from you and see if I can connect you with some of those. There are some out there, like if people become involved with, say for example, the law enforcement, they just have to ask for some of those services in the city of Atlanta, and then they will try to connect you with those services. So I don't know if you know of any more.
Yeah, well, Mr. Anderson, thank you so much for your work in this area. I think that, the intersection between homelessness and mental illness is a real challenge. The evidence-based model is to use a housing first model, which says that, people get supportive housing, permanent supportive housing first before they get, maybe before they have to agree to or stipulate to other types of services. But I think that finding that housing can often be a real challenge. And I think that, many of the nonprofit organizations I'm familiar with in the metro Atlanta area are, I think, increasingly getting into the mental health space. And many of the mental health organizations like Grady and others, I'm sure, are increasingly getting into the housing space. So for example, at Grady, we have a housing team that works on, connecting people to the voucher as quickly as possible and providing a housing first type model. But, I think that the services that you all provide are just such a critical bridge to getting people there. As part of ACT teams, the criteria for ACT teams is fairly complex, but, it oftentimes ACT teams require 2 or more psychiatric hospitalizations in 180-day period. Or people have not been successful with case management and intensive case management. So I would say, definitely refer folks to outpatient services, and then they can kind of determine kind of what the best fit is. And there really is a continuum of sort of options out there. If people fail one option, then they can go kind of to the next level of intensity.
Good morning. My name is Neva Jones Foster, and I'm the president of the National Council of Negro Women DeKalb section. And I just want to say, good job, panelists. You all have provided us with some great information. Thank you. I just had one quick question in reference to a person that might be mentally ill, well, that is mentally ill, and they're not willing to go to the doctor. They're not willing to take medication or provide or do any of the things that you all have talked about this morning. What would be step one, the first step, in terms of getting them help? Thank you.
Yeah, I'd be curious actually what everyone's perspective on this is, and I think that there are folks actually who fall into a gap right now that's not otherwise met, where that someone, you know, they are experiencing some sort of mental illness, they're not ill enough to be in the hospital, they're not ill enough to maybe even get an order to apprehend, and they're sort of there in this space that is sometimes very difficult. And I work with a number of families who are in exactly this situation, and sort of work with them informally. One of the things that we sometimes talk about is really sort of understanding what the guardrails are around what you would do if they were to be in a crisis. What would the behaviors be like? When would you call 988? When would you call 911? And sort of really knowing kind of what the crisis step would be. I think another thing is that if anybody is concerned, you can call 988. If there's a sort of crisis type situation, they can determine whether or not to send someone out and needing further sort of evaluation. But we at Grady have been talking about trying to develop some innovative programs to fill this gap, you know, and potentially work with and engage people who otherwise haven't been met by the mental health system in traditional ways, but who otherwise aren't sort of in the, you know, sort of legal system or in the hospital system. I think there's a gap. I think it may even require some legislative, you know, sort of solutions as well.
I'll take one of the questions that are on the Q&A from the webinar. If you are a nonprofit organization that can help with family resources, who do you reach out to?
So the question, like, should they reach out to the courts or to attorney
I would
groups?
say to a couple of places. Your CS Community Service Board. So whoever your community mental health service provider is in your whatever community you're in, and you can look that up on the DBHCD website and see what your provider, who your provider is if you don't know. But I would say that would be maybe the first place I would start for something like that.
And this is a provider that has services they want to make available to people.
Nonprofit organization that can help with family resources.
They might also contact, I know when in DeKalb County, whenever someone, you know, calls 911 with an issue or an event, we have a sheriff, they have and it's referred to as a mental health issue. We have a special group of deputies, a small group, but we have a special group of deputies that go out and at least, you know, can evaluate the situation. So maybe if they had access to that information, they could provide it to families when they went out there.
Okay, we're going to take one quick last question. Is there a way to create a more robust continuum of care? If we look at what we have done with food resourcing, while not perfect, could we do something similar?
Well, I think we are continually looking at that, and I look out in the audience and I see a couple of people that might be able to answer this question better than I, but I will take a stab. I think the answer is yes, we can, but we have to have the workforce and the resources to do it. And I know I've said workforce before, but we're very understaffed. It has gotten a lot better. COVID was very hard on us. We have tried to increase hourly rates for different people. Psychiatrists in Georgia do not make as much as they do in other states. It is very hard to recruit psychiatrists and psychologists. My own daughter left the field of social work and going to finish her degree in clinician to be a lawyer because the pay was so low. But now she's a public defender, so I don't know where that all came out. But anyway, that's an aside. But we are suffering in that area, so we have to increase that really before we can change anything else.
And I would just say, looking at our panel, maybe one of our other panels today might have some better answers than this panel.
So please join me in thanking our panelists for an informative presentation. And I think we had more questions on Zoom than we could get to, so those will be addressed later. We are now going to take a 10-minute break. 10 minutes. We're going to stay on track. Please be back for the second panel at 10:40. Okay, it's time to start our second panel. Creative solutions for the challenges encountered by hospitals, jails, and treatment facilities with individuals suffering from mental illness. The moderator for this panel is Dana Ashford. She is an attorney in private practice with the Ashford Law Firm, where she handles all types of probate, estate, and trust cases, including guardianships and conservatorships. Please join me in welcoming Dana Ashford in the second panel.
Thank you, Caroline. So our panel is going to discuss creative solutions regarding challenges encountered by different systems in the mental health arena. So the systems that we have represented here are, we have, and I'm going to let the panelists introduce themselves, but we have the judicial system, criminal justice system, community system, and hospital system. So I'm going to let the panelists introduce themselves, and then we'll get into the meat of this. So go ahead, Judge Wolk.
I'm Kelly Wolk. I'm the DeKalb County Probate Judge.
Good morning, Amanda Matthews. I'm a private practice attorney, and I represent a lot of hospitals throughout the state, private practice facilities. I guess I'm the hospital arm of what Dana had just mentioned to you. I do a lot of different types of practice, but also as part of that work, we represent a lot of facilities. They're medical providers, physicians, other healthcare workers, and as part of that practice, over the years, it has included a lot of mental health work. My firm, I have an entire staff, an entire team of attorneys and staff members that work with us on everything from involuntary commitments and subpoena issues all over the state. So I'm here to talk about the hospital angle of some of the issues we're going to be discussing today.
And good morning. I'm Renee Dreyfus. I'm a licensed clinical social worker. I am the Chief Clinical Officer for Claritel Behavioral Health, formerly known as DeKalb Community Service Board. We are the DeKalb County Community Service Board public safety net provider for the area, providing a wide-ranging resources of services we'll talk some about during the panel this morning.
Hi, good morning. I am Kareem Martin. I provide direct oversight over the health services part of the administration for the Sheriff's Office. I'm also the medical liaison for the Sheriff's Office, so I really oversee clinical operations within the jail and also provide that oversight for collaboration and communication with different entities such as DBHDD and Grady Hospital and so forth.
Okay, so what I would like to do is how many non-judicial people do we have here? Okay, so what I would like to do is to first ask our panelists how a mentally ill person might end up interacting with them. Some of it's self-explanatory, but I think it's important for to understand what these systems, how these systems work, and how a mentally ill person might be before court or end up in a psychiatric hospital or with Claritel and how they get there, and then obviously with the law enforcement system. So Judge Walk, can you go over and explain how the probate courts in Georgia deal with mental health issues and how that issue gets to your court?
Okay, so we're talking about people outside of my family. Okay, just making sure. So probate courts. My tagline that I'm trying to sort of get out into the universe is that probate courts are the only non-criminal court where folks get involved with the judicial system for mental health. So you don't have to get arrested. You don't have to be in an accountability court. You don't have to be facing a stalking charge or a trespassing charge or whatever. So we are typically the interface of community last resort. People want to come to us last. They will call 911 often in an emergency situation, which will then sometimes, more often than we would like, result in criminal charges. But if family and there's a misconception amongst a lot of folks, including law enforcement, that only family can come to the probate court and seek out an OTA. I can't tell you how many times I've heard from people, oh, I'm not part of the family. You only have to have observed the behavior in the past 48 hours that leads you to the conclusion that this person is an imminent threat to themselves or others. So we deal with family and folks who have direct interaction with somebody who is in crisis when they come in to seek an OTA, an order to apprehend, commonly referred to incorrectly, but we don't care, a 1013. The 1013 is actually the department form that gets them involuntarily committed. Our OTA is really just a request for an armed Uber ride from where they are to where they need to be in order to get that medical intervention. So that's what the probate court does based on personal information of at least two people who have observed, and I'll let you define observed yourselves, because in the days of Zoom and text messages and those types of things, and being on one side of the door versus the other side of the door, what is observing somebody's behavior? And now we have AI, so voicemail messages and all of those things are making all of this much more sophisticated. But that's sort of the initial conduit into the mental health system from the community through the court system. The court system then gets involved in the treatment process when the facility at some time subsequent, either as the result of that OTA or otherwise, the facility seeks an involuntary commitment. So I can't go and say my dad needs an involuntary commitment. I can say he needs to get put in front of a doctor who can make that decision. So those are sort of the two doorways that we see. Obviously, we have the guardianship side of things, which is often driven by mental health. It's a different legal thoroughfare, but it often runs parallel to the mental health challenges that we see.
I will piggyback off of that, Judge Walk, because as she spoke of the orders to apprehend. And let me also say there are a lot of acronyms that everyone in this industry throws around. If you find us doing that today, and we may do it simply out of habit, throw up a hand, wave at us. And that will remind us to explain what that particular acronym stands for, or kind of go into further detail. But where she, first encounters that order to apprehend request and those sorts of issues, I get involved with mental health individuals and when they do appear at the hospital. After that armed Uber ride that Judge Walk spoke of, and they do show up at the emergency room or at a mental health receiving facility, as the statute would refer to it, to have that evaluation. When physicians evaluate that person and determine that they are a mentally ill person meeting the criteria of the statute to be committed to the facility, that would start the 1013 process that you've heard everyone speak on today. And let me say, for any family members or non-judicial people that are attending, folks that aren't heavily involved in the legal community with regard to this type of law, just like I mentioned with the acronyms, there are a lot of forms. You'll hear about Form 1013s and 1014s and 1021s and 1052s and all other sorts of numbers out there. Thankfully, we have this wonderful thing called Google these days. I say that with somewhat of a jest, but it really is amazing how much information is at your fingertips. If you know the right thing to start Googling, it can send you down quite a rabbit hole. But also, there are some really amazing websites put out by several probate courts throughout the state. Obviously, Cobb, DeKalb, there are many, many others that provide a lot of information and resources simply on their website. So if you're part of if you have a family member or a friend or a concern, oftentimes that can be a good place to start, to simply get familiar with some of the terminology, some of the options. And I think there was a question earlier, for example, about where do I start? What's the first step? What would I do? Sometimes Google is your best friend in those sorts of situations because it is a very individualized and specific type of law and type of health practice that we're all here discussing today. But that was a long-winded answer. Obviously, I get involved through the health system, but not just through the 1013 process that Judge Walk mentioned. Also, there are many instances where mental health becomes an issue in a lot of different types of litigation. For example, my firm, we respond to subpoenas all over the state with regard to requests for mental health records. Imagine a situation, for example, where there is a child custody dispute ongoing. Say there's a hotly contested divorce underway, and you have one parent making allegations of another parent, or perhaps the minor child themselves has had mental health treatment, and there is some issue in that case, whether it's a divorce case, perhaps it's a juvenile court issue, and there are certain issues before the court. There are a lot of unique laws with regard to mental health records that people don't necessarily appreciate. Most everyone has heard of HIPAA, for example, but a lot of people don't recognize that Georgia law is extremely specific and extremely narrow when it comes to mental health privileges. It's very different and much more strict than your typical physical health records. And so my law firm and the hospital, we get involved in those issues as well. So it kind of goes beyond just an inpatient admission, but we get involved in all of those sorts of aspects when they happen. Renee?
Okay, and well, Claritel, of course, we're the community service provider, so we provide public mental health, substance use, and intellectual and developmental disability services, primarily for DeKalb County, but we see people from a variety of counties. The core of what we do is mental health services. So people come to us from a lot of variety of places. We are out in the community also assisting folks. We have a robust co-responder program. We've worked with DeKalb County Police for many, many years with that. We've had some newer programs online too with cities of Dunwoody, Dorville, and Decatur, really helping to deal with crises, mental health issues, substance use issues in the community. Of course, coming in from the courts, as well as the hospitals, as well as family or individuals just coming in on their own to our crisis center. Our crisis center is probably the most, or probably is the busiest crisis center in the state of Georgia. Considering where we're located, we are the largest bed capacity for the crisis center. The crisis center provides evaluation, temporary observation, and crisis stabilization. So anyone can walk in the door seeking evaluation. They don't all come in through a legal system or family. We have many people that walk and they know our services. We're very easily located. We're very convenient. So we stay super busy. In fact, I looked at the data. We have just from July through September, we served 998 distinct individuals in our crisis center. So it's pretty busy. So we also, besides our crisis center, we have our outpatient services, traditional outpatient services of outpatient counseling, psychiatric care, case management, peer support services. So people come to us seeking help voluntarily. Maybe a family wants them to come. We have associations with some of the probation, U.S. probation as well as local. So sometimes they're required to come for treatment. But we also are involved with the schools. We provide APEX services in the schools as well as other community-based services in the schools. So we're addressing individuals that are experiencing maybe not a mental illness per se, but a behavioral or emotional issue at a young age. And we want to address them early and be able to help them through the course of their care so that they don't end up having a long-term negative experience in their life and they can be successful. Many other resources, many other opportunities to come. We involve ourselves with accountability courts. We provide some counseling services for them with the jail. We have an in-reach program at the jail. So we're touching a lot of different aspects of the community, and we're always looking for new ways to reach out and make sure that we're more accessible. So one of the things that I think we learned through COVID is the most important thing is to be accessible, and we're looking for many, many ways to be out there and not just be in our offices and, you come to us. We want to come to you. We want to find ways to be part of the community and be able to provide the services where we need. We've actually, one of the newer things we did was we have a case manager working in Clarkston. It's called the Hub, providing folks that are newly in this country. They need resources. You talk about challenges with people that don't necessarily understand or recognize that they have a mental illness or need services, and to be able to help them start where they're at and what they need to try and help them. A lot of them have gone through tons of trauma, and so we're wanting to really work with that community as well.
Well, the sheriff's office does touch mental health on a broad spectrum, right? So as Judge Wolk mentioned earlier, the OTAs, the orders to apprehend, once that is a signed order, that is sent over to the sheriff's office, and then our deputies are dispatched to facilitate that armed Uber experience to get them over to a crisis center. But also, the jail also experiences over about 50,000 intake assessments a year, give or take a couple of thousand. And of course, every intake assessment, we also do a comprehensive psychiatric or mental health evaluation to identify what's needed, what kind of treatment, what medication is needed, what treatment program actually may be best fitted for that individual. How can we help collaborate or connect them with our reentry programs, such as DBHDD, such as Claritel, such as the InReach program that we partnership there at the jail, as well as maybe getting them additional psych services, maybe at Grady Hospital. So of course we touch mental health and behavioral health from a range of spectrum, not only from a medication approach, but also from a psychological approach, a services approach with a team of clinicians, psychologists, social workers, psychiatric care as well.
So our panel is focused on creative solutions to problems in your areas, in your system areas. So as far as the issues that you perceive as problems, for example, Judge Walk, when you have a 1013 or a 1021 and you make an order, is that the last that you see of the case?
So, yeah, unless they come back. So, I have truckloads of respect for Judge Harris and for Judge Bell. I think they're two uniquely qualified individuals. I can't even get the hospitals to tell me when they discharge people when I put it in the order. So I don't even know that they've changed them from inpatient to outpatient. I don't know that they've put them back out into the community. So the idea that Judge Harris presents, and we've had this conversation of how micromanagey do I get in care. So, I mean, I know that like, my dad and my stepmom are both licensed my stepmom is a licensed clinical social worker. My dad has a doctorate of social work. He's not licensed, so he can't actually sign a 1013 on me. My stepmom can. My dad gets really nervous when he visits DeKalb County because then he's got two people who can put him in a hospital. But we don't have the same. My black robe effect is broken in Cobb. People are not nearly as intimidated of me as they are of the other two. I don't know if yours is working, Hargrove, but mine is not. So we are working diligently with our CSB and our director to sort of rebuild some of the infrastructure. But some of the follow-up, some of the pseudo-pilot program stuff that we have been working on to get to, we don't get the follow-up that I think that Judge Riddle, Judge Poland, and I would all very much like, because it doesn't give us the opportunity then to say, oh, this person's really weakly, WEAK-ly approaching the end of their hospitalization, but they're going to meet threshold, but we may be able to be involved to get them compliant and do those kinds of things, but we're just not getting that kind of interaction. It's a ongoing process, but it is not as vibrant and robust, one of my favorite words, as I would like it to be at this point.
So that would be information sharing, data sharing about a patient that may have been through the cycle multiple times.
Yes.
Is it possible that someone, a mentally ill person, could be in Cobb County 1 month, in DeKalb County the next month, and the next month in another county,
Fulton,
and
then they go to Clayton, and then they come back to me, and then sometimes they make it all the way down to Henry. Sometimes they go up to Cherokee. Yeah.
And the same thing with the other systems, the community-based system and the law enforcement system, the criminal justice system. So is there any way for different counties to know what has occurred in the judicial system in other counties?
No, it's impenetrable. No, I'm just kidding. No, it is with HIPAA, it is incredibly difficult. So you've got so many. We had a meeting. We met before this so that we would look really smart. Sorry to spoil it. And like we had our poop in a group, but I'm going to ruin that just by being on this panel. But we tried to discuss, and all we do is come up with problems like this. So let me tell you, there are barriers because mental health is covered by HIPAA, and it is covered by, like, I like to call it super HIPAA, because everybody freaks out when you ask for medical records, and you have to, like, say the Scandinavian national anthem backwards with the standing on your head and give your blood type and all of those types of things. But then you also additionally have technology issues. So you have HIPAA and you have technology issues. So his system doesn't talk to our system fluidly. So somebody gets arrested, we may know that they have a criminal background check because that's much more freely given, but we're not going to know what meds this person was on, what meds they reacted to. So if somebody has like a reaction where all their joints freeze up from a long-lasting injectable. That was one of my more recent cases. The guy was like, I do not want Invega Sustaina. And it came out that he had gotten it before, and it caused all of his joints to seize, and he could not move. I wouldn't want that either. That's more than an intramuscular shot hurting. That's like serious problems. And it took a long time for him to be able to articulate that. But if you've seen that reaction, we're not going to be able to get that fluidly in Cobb from DeKalb. A lot of people go from Cobb to DeKalb. And then you add to that when somebody shows up catatonic and they're a John Doe, or they're refusing to give medical information. And then so we've got that information is blocked because we never actually get an identity on them before they're actually discharged. There are all kinds of reasons that we have where information is not flowing between us, and then our ability to capture that and maximize it and pick up at F in starting over at A and starting over at A and starting over at A every single time we interact with this person in the world is disheartening a lot, and I would like that to change. So fix that.
Amanda, do you, so your facilities have access, obviously, to their own medical records.
Correct.
Do they have access to medical records of other hospital systems?
They do not per se. And Judge Walk brings up a really critical point, and we're here, of course, today to talk about not just problems, but creative solutions. Excuse me, and I'm glad that we're using the word creative, because that is definitely the phase at which I believe we all are. It's interesting that in 2024 and where we are in just the information technology age, that we are still having communication issues like this. By the way, those aren't my hospitals that
No,
are
they
not
are not.
communicating to you. But I think the solution...
That is very true, for the record.
But I think it's a key point, and we laugh about it here, but it's a really significant issue. And I think the only way around it currently in 2024, and I hope that there are better solutions coming forth, especially now that, we're required to have electronic medical records. Everyone remembers the giant Herculean efforts it felt like it took to get us to where we are now, simply to have electronic medical records. And yet we are still struggling with this communication issue. So, we're not finished yet, I guess, is the spoiler alert for this story. But I think for creative solutions, I know our particular staff, as you've already mentioned, Dana, we do have the ability to communicate with our other facilities throughout the state. So if someone shows up in Henry and then later goes to Gwinnett or winds up in DeKalb and they've been at one of our other facilities, we certainly know about that. And that's a very easy check for us to make. If, however, they're over at Emory, for example, and then come to us, that's not immediately apparent. So we then have to get creative with our solutions. And one of the things is that we obviously network with other facilities. And there is, as was already referenced, I think, with the prior committee, there is obviously a shortage of workforce in the mental health area. I think it's a very tight-knit community. It's a small circle of individuals that practice this type of medicine and handle this type of law. So you get to know each other intimately when you've been in the industry for any length of time. But there's been a significant turnover, I know, from seeing from the medical perspective, from the hospitals, the number of social workers that changed, the peer support personnel that we have has changed. But the bigger you can make that circle, if you're part of that hospital network that handles this type of medicine, the more assets you can add to that network, the better, because certainly, my staff can call over to Emory or can call to Grady or wherever they need to call to check. Now, it's physically impossible to call every single medical facility in the state. So even that creative solution is what I'll call it, is going to have some limitations. So I think there's still a lot of work to be done, and the technology has not yet caught us up to where we need to be to solve some of these problems. But if we can become creative and we can learn to reach out and expand that network, then hopefully that does begin to solve some of these problems. It at least helps. And naturally, if you're able to have your staff communicate with a patient who is willing to say, well, yeah, I was in Grady last year, or I was at, any number of other facilities, that gives us a breadcrumb to follow. If we have active family members that have information to provide, that's a valuable, valuable resource right there. Because one thing that a lot of family members don't necessarily understand, for example, is that even if a patient does not grant doctors consent to share information with family members, a doctor can always listen and gather information from whatever source that presents itself. So that means if you are a family member and you have a loved one that has decided they do not want their medical team sharing information with you, that physician is going to have their hands tied. They're not going to be allowed to give you information. But notice the way I phrase that. They can't give it to you. You can always provide background information to the staff at the hospital, to the doctors. And so the individuals we have that still have a support system, that still have family members trying to assist, friends, just community neighbors that are concerned about them. Any source of collateral information that can be gathered is so useful, especially in those instances where we do have kind of that roadblock of looking at someone, for example, and the physician can look at you and say, it's quite clear this person's been struggling with this for a long time, but I have zero history on them. And that happens more frequently than you might imagine. So we're still working on ways we can improve that. But I think, a common theme that we found in the discussions that we've already had today and in getting ready to talk today is that communication is going to be the key to any sort of creative solution for some of these sorts of problems that we're experiencing.
So Renee, when someone seeks services from Claritel, are you able, or do you have access to any of their medical records?
Well, here's some positive news in this area. Because of electronic health records, there's something called the Health Information Exchange. And probably you don't even realize that when you've gone to a doctor these days, Emory and every place, and you're signing your consents, there's actually a section in there about, do I agree to be part of a health information exchange? I happened to notice that myself one day because we're involved in this whole health information exchange project. And it allows your information to go into this exchange where it can be shared. We are in the beginning of trying to bring that into our health record. There's a lot of information that can come in. We're trying to figure out what's usable, what do we really need to know, but you can learn that someone was at Grady and they were prescribed a medication or they saw a certain doctor. So we haven't actually implemented it completely yet, but we are in the process of that, and we're very excited about how that's going to impact us because, again, we often don't have any idea where someone has been treated unless they tell us or if a family member's calling us. So that's creative. That's something new. It's promising. We're not there yet. Similarly, our organization has been involved with the Georgia regional system to have somewhat similar. You'd think that the community service boards and the state hospital systems would be able to talk to each other electronically too. we're actually on the same electronic health record. It's a little bit different, but it's similar, it's the same product. And so there's a work group currently working on that so that we'll be able to know that someone has cycled through Georgia Regional, they've come through us, wherever. So there's some exciting things on the cusp. So I'm looking forward to maybe a year from now where we're able to be with that, because I think it's going to open up the door just a huge amount, because we're a lot of times, flying blind. I agree with the whole thing about, I remember when I was a hospital social worker and a family member would call and I couldn't give them information, but I was eagerly like, is there any information you'd like to share with me? I'd be glad to listen. And you'd learn so much. So I think it's being willing to communicate and being willing to open yourself to listening, taking the time to, hear from a family member or someone that's important in that person's life, to be able to get that communication, because it's going to really help a lot of times in knowing what is going on, what are the situations, because sometimes you don't know. So some promising things. I'm looking forward to seeing where we get with the electronic communication.
Thank you. Mr. Martin?
So we have a couple of things that we have to kind of highlight and mention, right? So we have HIPAA, we have release of information, we have protected health information, and we also have health information exchange, which the jail also has to play a part in all of that, right, to make sure that we're staying within our realm. However, when you have a institution like the sheriff or the sheriff office that is mandated and has to facilitate continuity of care, then I have to find a way where I can have conversations with medical providers, with Grady, with outpatient services, with inpatient services, and still understand that a physician, a clinician's probably worst nightmare is initiating a new treatment plan, care plan on a John Doe or a Jane Doe, right? Someone who has had the Invega injection and has had those adverse reactions and the joint seizing up, and we don't want to go through that same issue again and possibly contribute to their demise. So what we've done is we got with Grady Health System, and we're able to access Grady records, Epic records, using the Epic system, because the sheriff office, the jail, we're also medical providers. And in order to facilitate continuity of care, we need to also be able to see what the treatment was, what medication they're on, and how we can facilitate that while in custody and continue their care. We also have a process of release of information. Anyone coming into custody also has to sign that document. Just like they're signing a consent to treat, they have to sign a release of information that allows us to reach out to New York if they're being extradited, to get that medical information, to get their medical history, to reach out to Emory Hospital and have these conversations, because we also have to facilitate their outpatient services, their orthopedic follow-up appointments, their neurology follow-up appointments. And once they go to all these different physicians, these different outpatient services, they come back to the jail. And for the time that they're in jail, we are their PCP. So we have to make sure that we're also facilitating their care, making sure that if they're on the appropriate medication, or if it's a medication outside of the formulary, that we have a process to facilitate that as well. So I think right now our solution has been that access to Epic, to the Epic system, the Grady system, where we can see and kind of have that conversation and facilitate the continuity of care from that standpoint.
And as far as when you have someone in custody or they come to see you seeking services, do you find that they are not able to give their medical history, or they don't want to give their medical history?
So I'll give you some perspective around that. When you have an average daily population of 2,200, and you have about 70% of that population is mental health, and you have another 35% of that daily population that's actually on psychotropic medication, on their individual treatment plan, a lot of times the jail gets the mental health that probably shouldn't be in jail, or that have to be in jail but don't have the capability to give their mental health history, to give their medical history. They come in, they're cachectic, they're in a state of psychosis, they have schizophrenia. We have to be able to navigate through that. And yeah, a lot of times they're not able to give their medical history. They don't want to give their medical history. I don't think anyone coming into a detention center or a jail is going to willingly give information. But we have a process where they can always have the opportunity to submit a sick call, to speak to someone, to say, okay, maybe I'm not as agitated or irritated from when I first came in. I can now maybe a month later, 2 weeks later, have that conversation because I actually do need that help. So we have that process as well, but we can also start them on a treatment plan from an assessment from their psychiatrist during the intake process, the 14-day assessment, which allows us to go back and revisit to see kind of what's really needed from a psychologist, a psychiatrist, your medical director, your physicians, your nurse practitioners. So we always have those levels we can always revisit, or if not, we can start them on a treatment plan. Oftentimes, out of none, we are starting a patient on a new treatment plan. So we have to go through that testing period. We have to try them on the Invega, the Abilify injection. That doesn't work. We try them on a different psychotropic medication. If that doesn't work, we try them on a peel medication, a crush and flow medication. Are they hoarding medications? Can we not give them pills? We have to do the crush and flow. We have to do the injection. So we have to be able to try different approaches and different alternative because not facilitating care is not appropriate. It's not an answer.
Let me add briefly to that too, just with my experience with hearings that happen, and I bet Judge Walk, you've seen this as well, is that sometimes a patient who might not be willing to provide information simply in a clinical setting, once they get in front of a judge or they're in a hearing, they have an opportunity to speak, it may be that feeling of finally someone's going to listen to me. They might be willing to share more information. I know we always keep at least one hospital staff person with us throughout those hearings so that, oftentimes, for example, our physicians testify and then are excused from the proceedings so they can go tend to patients and those sorts of things. But we keep social workers and coordinators in the room so that they can take notes. Even if it turns out to be something that's not accurate, it's still another breadcrumb, another thread to follow. To try to get just a little bit more information. And I have seen more than once it happen such that even though Judge Walk thinks her robe effect is broken, I've seen it more than once where, simply having a judge, give them advice and say, you realize, you say you don't want to be here. One of the ways you get to leave is by starting to take your medication. That's going to help you. You realize that, right? And so, family members, I hear from them all the time, they're very frustrated and medications are oftentimes a big subject of frustration where, doctors are recommending medications, patients are refusing them. And so there's sort of a standstill moment that happens. And sometimes, having a hearing, having a judge, having someone in authority at the jail system, having someone other than family give them that advice to say, this is what you need to do in order to get something else you want, whether that's simply being discharged from the hospital or from the corrections facility they're in, and that can have a tremendous effect at times. So.
Go ahead. I was just going to add too, as a community provider, I think most people do give us information. Most, especially if they're voluntary, if they're coming to the crisis center, they're involuntary. It may not be someone that is as willing to give information. Of course, the biggest, I think, barrier, of course, in our crisis centers, as far as getting information, if a person comes in acutely ill, they're not able to necessarily be thinking clearly enough to be able to give us that information. So sometimes as they begin to clear up, they begin their medications sinking in, they're feeling better, they become more willing to provide information. Now, providing information and then being willing to sign a release to get additional information, that's a lot of times where we run into barriers, because someone may feel like, well, I don't want my primary care doctor to know I'm coming to you for mental health care, or I don't want this other person to know I'm getting mental health care. So they don't want to sign a release for us to get information. So sometimes we're just relying on the information that we have from them.
So Renee, your facility is, how long can people stay at your facility?
Okay. In our crisis stabilization unit, the average length of stay is about 5 days. Typically 5 to 7 days is the average length of stay for CSU. Now, we do have some times where people stay longer. And of course, if someone needs to stay longer, sometimes, of course, if we're getting into a 1021 situation, we may have someone stay there 2-3 weeks. But on average, people are coming in and out in 5 days. One nice thing we have, and we've been utilizing this a little bit more recently, is the ability to have people in what's called a transition bed. So we have 2 beds on our crisis unit that can be used for transition. We actually had a really wonderful story of an individual that the benefit of the transition bed was just exactly what you would want to see happen. Transition bed allows a little bit more time. You can stay for up to 30 days with the idea that the person is engaged in community-based services. So they're still housed at the crisis unit, but they're out going to community-based services. We had this young woman with schizophrenia, still fairly young and early in her illness, but she was in the crisis center, but she was willing to do something more than just come in and out. So we moved her into a transition bed. We engaged her in our psychosocial rehabilitation day program. So we had staff that picked her up each day, took her to the day program Monday through Friday. She began to engage in services there. She was homeless. She had family that was supportive. However, she couldn't return back to live with them. We contacted the COC, coordinated entry. We were able to get her evaluated and then connect up with our own permanent supported housing. We were able to get her into the housing right where she was hitting that 30-day mark. And so she moved into housing, continued with the psychosocial rehabilitation program when she was released from the crisis center. She's already moved into our peer support program, which is more, the psychosocial rehabilitation program is more skill-based, really helping someone with managing their mental illness. Peer support means the person is really more stable in their illness, they're able to advocate for themselves more and move ahead. And she has just, we helped her re-enroll in college. She was only about half a semester left in her college career. And so she's re-engaged in college, so she's finishing up her college. So that was one of the most exciting stories that we've had of success with how that whole transition bed is supposed to work. And I'm hoping to see more success stories like that. But that's an unusual situation.
So within all of these systems, judicial and hospital and community and criminal, is a common problem, and we already talked about one common problem, which is lack of information sharing and continuity of care. And let me ask you, Mr. Martin, are you able to see if someone has been hospitalized at a psychiatric facility? Do you get that information as well as particularly for Grady medical information, or are you not able to see that kind of thing?
So as long as they've been to Grady, and this is something that we're going to continue to discuss with hospitals in the metro Atlanta area. We're moving over to Emory Hospital now because sometimes we do have patients that go to Emory. But as long as you've been to Grady, I can see everything that you've been facilitated for at Grady Hospital. So I can see your psychiatric history, I can see what medication, what surgeries, what treatment, if you have any outpatient psych needs, mental health needs, behavioral health needs, if you've gone to Emory. I can see when you've gone to Emory or whatever hospital, so I can actually call them and say, hey, I know this patient has been there, they're now in our custody, they're in our care, and we would like some documentation to continue their care.
Okay. And is that the same for the healthcare exchange? Are you able to see psychiatric information?
Yes, if they were in psychiatric hospital as part of the health information exchange, yes.
Okay.
Or like a Grady or Emory and receiving mental health care through that, yeah.
Okay. So and I'm going to go to the next topic, which is I believe to be a common problem in all of these areas, is lack of housing. And I would like to know in your specific area how that impacts your particular system, and whether, if the housing issue could be addressed, and I know it, as Judge Harris said, it's going to take a pile of money and more workforce, but if the housing issue could be better addressed, is there a consensus or a feeling that we might not have as many mental health crises that we are seeing currently, if there was more housing available?
With the housing, I've seen a correlation with homelessness, unsheltered housing, in relation to the incarcerated population. And it just seems to go hand in hand, especially if you're unhoused. There's a lot of psychosocial needs behind that. And once you have psychosocial needs, you typically have mental health, behavioral health needs. And what we've probably seen with our partnership with Decide DeKalb, with the ACT team, with the NIC Project, with Claritel, is once an individual has housing, the recidivism kind of goes down. They start to get that case management they need, and they start to get that medication attention they need. But if they don't have the housing, then the medication, the psychiatric care, the mental health care really becomes almost void, because they're focused on housing, they're focused on their safety. So we've always seen a connection with housing, with the incarcerated population, and with mental health.
Yeah, and the unhoused situation is growing. We've seen in DeKalb County many more unhoused than we've had in the past. In fact, even just when I was looking at the data from our crisis center for admissions to the crisis center, that same last quarter, 42% of the admissions were unhoused. And as we get into the colder months, we know it's going to increase. So, and we have some folks that they cycle through. There aren't a lot of resources for housing. We talk about housing first, but we have to have the housing for people to move into. And it's getting harder. The rents are higher now. Even for vouchers, or like we have permanent supportive housing, we keep seeing the rents going up, more and more barriers in that landlords are becoming more aggressive in their background checks. People that we've been able to house for years in apartments, that they're now saying, no, that person can't live here, even though they haven't reoffended in maybe 10 years. Like, no, they have that charge, they can't live here. So then we're scrambling, looking for alternative housing for folks, and it becomes harder and harder. We need more money, we need more resources. We're looking at opportunities for housing, finding funding for that, but it's a challenge.
I agree completely. One of the things that I have to discuss with our physicians regularly, however, is that we cannot hold someone in the hospital simply because they don't have housing and they don't have somewhere specific to go. Now, that's a very different scenario if I have someone who would be physically unsafe in something like a public shelter environment. If that situation arises, then you do need to follow a 1021 process and speak with your staff about the involuntary commitment process. That's a separate issue. But if it truly is simply this person has nowhere to go, but mentally speaking, they're back at a baseline such that they can function in the community, then that doesn't meet the statute in Georgia to hold someone in the hospital. It's particularly difficult in situations where someone, either as a result of their mental illness or perhaps as a side effect of their mental illness, they are choosing to not accept resources to provide them with housing. I've seen that many times, and that can be especially difficult for family members to hear. We see family members in crisis. They're reaching out to the hospital to say, please keep my loved one in the hospital. I can't have them come live with me, but they have nowhere else to go. And when you speak to the patient wants to be released onto the street. You see news articles sometimes about, accusing facilities of, quote, dumping people on the street. And I know the healthcare professionals I know and work with are very dedicated and very conscientious people. No one that I have the privilege of working with wants to, quote, dump anyone anywhere. But in this country, you have the constitutional right to decide where you're going to live. And family members may not like it or agree with it, but if a person is making the decision, no, I want to go back to shelter X because I don't want to go live with my mom, and again, it could be the mental illness. It could be simply because they have a bad relationship with their mother. It could be any number of reasons, but it is an issue, and no amount of convincing sometimes is going, or no amount of counseling sometimes is going to convince someone that a shelter environment might not be in their best interest if that in fact is where they believe they want to be. Obviously, sometimes you also have drug dependency issues that are contributing to that. They want to simply be released on the street so they can go back to whatever, location they were previously getting, illegal drugs. That comes into play as well. So it's a balance that hospital facilities have to take into account, of course, to decide, even if we don't think this is in their best interest, do they have the constitutional right to choose to live this way? And the short answer is yes, unless it is a mental illness situation where they are going to be an imminent threat of harm to themselves or others, or they're so unable to care for their own health and safety that releasing them is an imminently life-endangering crisis. And everybody who does 1021 hearings knows those phrases by memory. So it's a very difficult issue that I think does go hand in hand with it, and there aren't any easy answers that I've seen.
In my limited experience with some of the accountability courts, in other classes of courts, in their intake meetings, the very first question in every single intake meeting for an accountability court is, does this person have stable housing? Period. So if you're talking about how important housing is to the process, that is central. I grew up in a time where living in the back of a van was considered homeless. We call it unhoused now. Now it's like you're some cool adventurer on TikTok. And so when we talk about creative solutions to housing, there are acceptable standards to what is stable housing that is a different lifestyle than was acceptable in the 80s, 90s, early 2000s. So when we start looking at things, I think that those are the kinds of things that are going to get more momentum, investment in some of the failed motels that are becoming very small condos, basic kind of things that some of the counties, including Cobb, are looking at. Some of the activities of MUST, which is an amazing organization up in my neck of the woods, God's country as we call it. So nothing is solved. But I think that as we look for solutions, those types of things are going to have to be considered as housing where they wouldn't have been 10 years ago.
Renee, can you explain what, and it was referenced earlier, what 988 is?
Okay, yes. 988 is the suicide helpline. So it is the first place a person should call if they are having thoughts of suicide. Now, you can call for other reasons as well, but that's the main reason that it was developed, is to be the suicide helpline nationwide. And if a person calls 988, they'll talk to a counselor who may determine that the person is at imminent risk and may need to have someone to come right out to the scene. Or they may be just someone that they talk to on the phone. They may give resources. It just depends on the severity of the situation as far as what happens. I know in Georgia, 988 is run through the Georgia Crisis and Access Line, GCAL. But it's the nationwide network, and I know one of the things, I was just at a conference earlier this week, that nationally what they're working on is allowing for, like, say, you know, I'm sure many of you have cell phone numbers that are not local numbers, so it depends on where you got your original number from. But if you called today and your number is from a New York line, and you're here and you're calling 988, it's going to route to that New York jurisdiction. So they're working on changing it so that it would route to the local place where you're at. Because, you know, if it goes to someone in New York and you're needing local assistance, then there's a lot of scrambling around to try and then connect. So they're really working on building out that infrastructure a lot more. But it's a great opportunity for folks to have someone they can call, not having to call 911. I mean, certainly 911 is available for those more severe situations, but definitely 988 is the place where you can just call if you just need to talk to someone, let alone need to go somewhere.
And that's different from the mobile crisis unit, correct?
Correct.
And can you tell?
So, yeah, so, you know, the state operates the mobile crisis through GCAL, BHL, that sends folks out, counselors, peer support specialists, they work throughout the state. We, at Claritel, have our own co-responder team, which is something that we've been doing since the 90s, long before the new co-responder laws went into effect and everything. We've been very grateful to have a great partnership with DeKalb Police since the 90s to provide co-responder care, which partners a police officer with a clinician. They can go out on the scene, talk with individuals, get them the support, either and most situations are resolved on scene, but then if the person needs to go to a hospital, to the crisis center, we're able to get them transported there as well. We do follow-up care with that as well. We have case managers that will follow up. In fact, some of the situations where it might be someone that's a familiar face for the co-responder team, they may go out regularly to go check on a person, you know, check in, see how they're doing. Are they following up with their care and things like that? More recently, we've engaged in co-responder teams where we have a case manager working with the city of Decatur, one with the city of Dunwoody and Doraville. And then if they need a licensed clinician to consult with, we have a licensed clinician that will, on telehealth, on video, be able to talk with the individual, determine if there's a need for the person to be hospitalized, or if they just need someone that's needs additional counseling from a licensed clinician. And if a person needs to be hospitalized, if they need a 1013, the person on the telehealth system can initiate that and make sure the person gets to where they need. So it's been great, and I know the response and the ability to be able to work in the cities has been very helpful, I think, for the cities as well.
Anyone else want to comment? So, somebody, may have been you, mentioned guardianship earlier, and that a lot of the orders to apprehend or 1021s kind of go hand in hand with family filing for guardianship. Just to, you know, I do that myself and have plenty of people come in and think that if they get guardianship, that they're going to actually be able to force their loved one into a treatment program or to force them to take medication. So can any of you comment on whether that's actually the case?
Do you want the legal answer or the practical answer? So there is a U.S. Supreme Court case that came out of, it was an Atlanta legal aid case, actually. Shout out to legal aid. The Olmsted case, which essentially came out of some of the atrocities at Milledgeville, and some other things that resulted in a DOJ settlement, blah, blah, blah. A lot of your angst results from that. And there was a sort of spike in awareness that you can't involuntarily commit somebody just because you're a guardian. I can't involuntarily commit my daughter, who is 13, just because I'm her parent. There has to be a medical reason for that. One of the major misconceptions about guardianships is that a guardianship removes the right to refuse medical treatment because it grants the right to consent to medical treatment to somebody. In reality, legally, if I have a guardianship over me, I still have the right to refuse medical treatment. If I don't want a mastectomy, I see the 3 minutes. If I need to get a mastectomy, if I need to refuse mental health treatment, then I still retain that right. The guardianship in and of itself does not allow that. This process still has to go through each time an involuntary treatment needs to happen. What is unfortunately occurring is that as we've gotten farther away from the Olmsted decision, there is a lack of knowledge of that within the mental health community, and we have people sent to us where their guardianship petition, their emergency guardianship petition says, I need this so I can consent to medical treatment. Such and such hospital sent me here to do that. They're being directed from the hospital for that sole purpose to get a guardianship, emergency or otherwise.
Not my hospital.
And so we are then left with, we don't have a basis to grant the guardianship because that's not relief that we can give you, is the right to consent to involuntary medication on behalf of somebody else. So yes, it's a huge problem. It's a huge confusion. It's obviously confusing the families. It's confusing the mental health professionals on top of that.
I know we're short on time. Can I add something really quick, Dana? I think that was so well stated that the ability to consent does not remove the patient's ability to refuse. I think those are two very, very important concepts. And just for the benefit of the medical practitioners and the legal folks that are with us, OCGA 37-3-163 is what deals with medications. And I'm just going to read briefly. It shall be the policy of this state to protect, within reason, the right of every individual to refuse medication, except in cases where a physician determines refusal would be unsafe to the patient or others. It goes on and states that a concurring opinion from a second physician must be obtained before medication can be continued without the patient's consent. So what that is saying is that if you are a medical provider or at a hospital or any other sort of facility where you're providing medical treatment, you have to have at least two physicians attest that the patient is going to be unsafe. And again, there's not a lot of litigation on this. There's not a lot of extra detail. What does it mean that they're unsafe? Your guess is as good as mine at this point. But there's very limited case law on it, but it can be done. It's what some might call a little loophole there, but it's not. It's a very difficult issue. It's difficult for families and patients and physicians alike. So.
Before we move on to Q&A, we're going to hear from a special guest for a few minutes. It is my pleasure to introduce DeKalb County Sheriff Melody Maddox.
Good morning, everyone. First of all, I don't stand here with this pink on because it is my favorite color. I stand here in honor of our family, friends, and loved ones that has passed along because of this deadly, ugly illness that's called cancer. But I also stand here with this pink for those that are fighting and are still fighting the good fight. And I want them to know that DKSO and the sheriff, we stand in the fight with you. First of all, let me just say thank you to Judge Hargrove for putting on this symposium. This is a very informative and much needed conversation. This is a conversation that some people don't even like to talk about. I, for one, am very familiar with mental health. I have a very close family member that is dealing with mental health illness that I have to sometimes call, make sure the medication is taken, make sure they're in the place where they're supposed to be. So I know you all thinking that the sheriff don't have to deal with that. Yes, you do. So it's more than just having those that are incarcerated at the DeKalb County Sheriff Office, which is why I'm a part of the Board of Directors for Claritel, because I want to make sure that I am informed on what's going on so that we can make sure that those that are incarcerated, one thing I believe in, that these people need help, not handcuffs. It's just unfortunate that we have become the drop-off point for those that are suffering with mental illness. But the good thing about it is that we have a relationship with our Solicitor General, our District Attorney, our judges that are here, and other community partners that will assist us in making sure that these individuals that are incarcerated get the necessary treatment that they need. It's important to know that not only that, as the sheriff, the first thing I did was walk in the door and found someone that I could depend on and have someone to be the liaison in the community, which is, of course, my health service director, the newly appointed health service director, Manager Martin, that sits here on this panel. He's knowledgeable. He has the medical background. I'm not a medical person. I don't know anything about it, but I'm learning. And I want to make sure that we have all the necessary information to make sure that these people get the treatment that they so deserve. Some people just can't help it, and I've seen it. And like Director, I have to change his title, Director Martin said, when you have 2,200 inmates that are suffering, and 70% of them are suffering, what do? I can't just say, I'm not a mental health facility, that's not my job. I have a constitutional responsibility to make sure that they get what is necessary, whether it be medical, when we talk about the pills or medical treatment or therapy or both. It all depends. So I just want you all to know that I'm very much in support of this. So again, Judge Hargrove, thank you so much. Thank you to your team. Thank you to everyone that's on this board that's given us all the information. And I want to thank you all for even coming to be a part of this symposium to make sure that you get the information as well. So again, thank you and welcome.
Thank you, Sheriff Maddox. Okay, now it's time for Q&A for the second panel. If you've got a question, raise your hand. We'll get the microphone to you.
Good morning. My name is Priya Srinivasan. I'm a scientist by profession, and I'm also a doctorate of public health student. I recently completed my practicum with Commissioner Terry's office on breaking the homelessness jail cycle. So my question to the panel is, I focus on prevention in all aspects. Would early screening and expansion for mental health condition, and make it more normalizing and help break the stigma and, break the whole cycle? Thank you.
I think one of the things that we kind of have to go back to is, this was a conversation we had earlier this week as well, in the adolescent sector, in the high school sector, even in the middle school sector, we have to go back to start including psychosocial services, psychology services, to understand and identify some of the hidden diagnoses or needs for these students, their housing conditions, their family conditions, their background coming through the high school area and starting to kind of face society. We have to have that psychosocial introduction to them to understand what their need is and how we can support them in society, how they can be sustained in society with some of these deficiencies or defects that they may have or they may come across. So I do think psychosocial services or psychology services at a adolescent age, at a high school age, to kind of help guide them and help them understand and propel them and get them ready to face society and some of the barriers that we do face in society from a mental health standpoint.
I'll just add too that, the state of Georgia has had the Apex project now for, I think we're going on 6 years, might be 7, which has brought services into the schools, which has been phenomenal. And I know that a lot of the schools, that even if they don't have Apex in their schools, they're beginning to develop more resources, bringing counseling into the schools, working with families. The nice thing about the Apex program is that it's not just me providing counseling to a student, but it also works with the teachers, with the administration, it works with the families. So it's developing the knowledge and the awareness to help with prevention, to help to be able to know when someone is beginning to struggle, to intervene early. So those are the types of things I think that really are beneficial for our youth, to intervene early and not just have them go through school, maybe drop out, maybe end up in a life of crime or whatever might happen. Getting there early is so important. I really love the structure of the Apex program, and I would love to see more of it in more schools.
So I have a question. Speaking of juveniles or minors, and I've never had to deal with this before, but what is the process of an involuntary commitment for a minor?
Orders to apprehend for minors who are 17 and under, or who are under 17, that's what it is, goes through juvenile court. So the pickup order is handled through the juvenile court. Anybody who's 17 and older comes through the probate court. We don't do
And
anything.
there is a similar process at the juvenile facilities that we go through, similar to the same process we use for adults. Obviously, it's in front of a juvenile judge as opposed to a traditional probate judge, but the process is very similar.
I have a question from the webinar. How does Claritel work with hospitals such as Emory, Decatur, Hillendale, and Grady, as well as others, to assist unhoused who are in the ER and need mental health services? What is the process? The issue that I see is unhoused go to the ER for shelter, and many have mental health issues but are just put back on the street.
Our crisis center worked very closely, especially with DeKalb, Emory Decatur. I still have DeKalb Medical Center in my brain. And we work very closely with them. We have folks that come from the ER into our crisis center. And, again, there are so many unhoused individuals. It's a issue for us at the crisis center. I mentioned that, over 40-some% in the last 3 months were unhoused. There's not enough housing out there. We do work with individuals. We actually just became a housing support specialist provider. So we are working with more individuals that are getting vouchers, hoping to keep them housed. We're looking towards actually our own selves finding additional housing. We're working on some projects that we hope that we'll see come to fruition in the next year to have some additional housing that we're providing, and not we're going to landlords to look for housing, but we're looking for ways to increase the housing resources for people that have mental illness.
I have another question from the webinar. Can the panelists discuss the challenges encountered when individuals in crisis have both mental health issues and developmental disabilities due to the different departments, processes, or resources at DBHDD, which can affect a choice or exclusion harmful to these individuals with complicated issues who probably need all of the resources available?
So
That was a question submitted by a probate court judge.
So from the correctional aspect, what we have to do, and I've worked in the hospital for about 9 years, right? A cardiac trauma 1 hospital as well as a psych institution. And what we kind of did with the jail administration is kind of redesign the jail to facilitate a lot of the mental and medical needs. So we do have an acute psychiatric floor, and we have an acute medical floor, and we have a step-down mental health floor. And when we come across individuals with developmental disabilities or psych disabilities, we're able to house them appropriately in these acute units where we can have 24 observation, where we can provide them with that acute medication-assisted treatment or that psychological treatment. But then we also work closely with our Claritel and our DBHDD partners to facilitate 1013s when appropriate, to get them to a stabilization unit, because of course forced medication becomes an issue when you're in a pretrial facility, and those are lines that we typically don't want to cross or you can get in trouble. So we have our partners we work with to get them stabilized, but also for developmental disability, it becomes the responsibility of the sheriff's office and the jail to bring counsel up to date, bring the presiding judge up to date as to what are our findings from a clinical perspective, because like I said earlier, we are also clinical and mental health providers. So we also have to let counsel know, hey, there has gone through, some assessments. They may have some sort of autism or developmental disability. They may be on, this may be the history, or we've confirmed the history from outside treatment facilities, or we can no longer facilitate the acuity needed to get them through a therapeutic state from a psychiatric level. So we can send them to get a court order to send them out to DBHDD, to a Georgia Regional, or to get them to a stabilization center in the community. But it's all about that collaborative communication to identify who has the services and what kind of services we can facilitate either at the jail or at these other facilities, our partners.
One thing I'd say too is that DBHED, I think, has taken a very proactive look at including developmental disabilities in interconnecting with mental health services. There's what's called the CCBHC, the Community Mental Health Center projects that we at Claritel are currently in the beginning stages of becoming a CCBHC. And CCBHC is something that comes from the federal government, SAMHSA, and many programs around the country. What DBHED has done, which is a little bit different, is they've included the expectation that we include intellectual and developmental disabilities into how we address our services. We are actually going through an accreditation program right now to become certified as a dual diagnosis mental health IDD provider, and it's really allowing us the opportunity to really look at how things were so siloed before. How can we bring things together, because we do have so many individuals that have that type of dual diagnosis, and it was always separate. No one really put those things together. I know DBHED is working on, or has some crisis stabilization units around the state that have specific beds for individuals that have intellectual developmental disability or dual diagnosis. And I think we're going to be seeing a lot more attention in this area than we've ever had before.
I'd also like to add, because that's not enough and complicated enough. Hey, Judge, whoever you are. We are coming to a point in our elongating the normal course of human life where we have people who have developmental disabilities, mental health disabilities, and are being diagnosed and being affected by dementias. So we have folks who need assisted living while they're receiving mental health care, while they're receiving assistance for things like autism or, Down syndrome, which was never a long-term care issue, but we can now have elderly, by definition, by statute, folks who have a lot of these coexisting diagnoses. And so if you have somebody who is violently sundowning and autistic and and on top of that, psychotic, and you are trying to figure all of that out. If you want to solve the housing crisis for that, like those who made millions and millions of dollars off of assisted living back in the 80s, feel free to tackle that problem and you will be very well off. So you're welcome for my tip of the day.
I think one thing to stress as well is that so much of this is just county specific. I would love to sit here today, I think we all would, and say, here's a great list of, the exact places you need to go for all of these exact problems. And as I kind of alluded when we started, Google, of course, is your friend, but it's going to be very specific to the issues you're dealing with and where you're located, or where the patient is located, I should say. And hopefully you are in an area that has great resources that we've been talking about today. I think DeKalb does a wonderful job with the types of resources. Some counties struggle. I think it was mentioned on the earlier panel. It's great to look to other counties to see what are they doing and what's working for them. But if you're in an area that has limited resources, look to neighboring counties, make those phone calls, and find out what you can do to potentially, take advantage of some of those opportunities. Sometimes it's not limited just to residents, but you'll have to get creative looking outside your jurisdiction. So just a word of advice there.
And multidisciplinary panels are becoming a very popular thing. So if you keep asking the question, I've got a family member who is A, B, C, and D, and one facility deals with A and B, and then they have a relationship with D. They may have some sort of a multidisciplinary panel or committee or whatever that's working together to try and bridge some of those warm handoffs from the jail to the housing folks, from the hospital to the jail, from the whatever. And so if you keep asking those questions, don't just go in and say, I know you handle A, I need A, and then go try to find somebody who handles B. Say, I've got this problem with B as well. How do you have any recommendations or relationships to help? Because you will always get a no to the question you don't ask.
And speak with your commissioners and, all of your other representatives if you are in a county that is lacking in some of these resources. It's a great opportunity to say, I attended a symposium in DeKalb, and here's what they're doing there. Or, I heard from Judge Walk that in Cobb County they do X, right? Because educating some of your representatives in other counties can be exceptionally helpful as well. As was mentioned earlier, it is fortunately talked about much more now than it ever has been. And when funds are being allocated, squeaky wheels are getting the money or the grease, as it may be. And so if they're hearing from constituents, this is something we're lacking. The funds are always going to have to come first. And so that's not an immediate fix, of course, but I think everybody participating in this discussion has a shared interest in trying to improve this area for all of your community, and I think that's a great place to start.
Please join me in thanking panel 2. I also want to give a thank you to Anthony Drummer and his business, Drummer Imports. He is a great friend of the court and a sponsor today, so thank you. Okay. We're going to be back in here for our keynote speaker at 1:10, and feel free to bring your lunch, sit down, and enjoy. Thank you all. Now it's time for our keynote speaker. Now I have the pleasure of introducing the person who will introduce the keynote speaker. Attorney David Long Daniels is a good friend of the court, a partner at Squire Patton Boggs, and he is here to introduce the keynote speaker.
Thank you. I've got the toughest job in the room. I've got to introduce someone whose picture is on the wall. But I've known Michael for a long time. That says how old we are. But a few things that people may not remember about Michael. In 1986, Michael was the first African American since Reconstruction elected to the Georgia General Assembly. From Clark County, that's correct. And he led the Georgia Division of Family and Children's Services. When I met him, he was the Commissioner of Labor talking to a lowly young lawyer trying to find his way. We all know he was the interim superintendent of DeKalb County, and he's done a great job as the CEO. But let me tell you a little bit about my friend Michael that you may not know. Somewhere I read that what you've done for the least of them, you've done for me. And Michael is the kind of guy that lives by that. When people were sick during COVID, he came to the rescue. When a certain hospital closed its doors, he helped the effort to find a way for people, poor people, to get health care. When people were hungry, he led food drives and rallies so that they would have food to eat during COVID. When people were homeless, he tried to help. Please allow me to welcome my friend, a man who served with honor and dignity, not only the DeKalb County area, but the entire state of Georgia, Michael Thurman.
Good afternoon. And first, David, thank you so much for your friendship and your support. Let's give him another round of applause. An outstanding member of the bar. Delighted to be with you. And of course, the best probate judge on the face of the planet, Judge Hargrove. Judge, give her a round of applause. Thank you so much for the vision that gave birth to this ongoing effort to build partnerships and focus attention and resources for people and families who may be facing issues associated with mental health. It's been an honor and a privilege for me to stop by on multiple occasions, and in a broader sense, the first and most important message I wanted to share with Judge Hargrove and this group is to say really thank you for the opportunity to stand and serve with you for the last 8 years as CEO of DeKalb County. It's been a pleasure and an honor that you all gave me, that I will value throughout my life. Judge Anderson and these judges sitting behind me, which is kind of creeping me out, you know, to have these judges behind me watching my back. I don't know. But thank y'all so much. Let's give a round of applause for everyone. Thank you, Judge. Thank y'all so much. Got the chief back there and Judge Stroud, who we honored at Decatur City Council meeting not too long ago. So thanks again. The good news is I don't need or make long speeches now. Wonder why? The main reason I went to vote early yesterday and I went there in the ballot and my name was not there. And I'm like, that's different. But more important than that, the most provocative and persuasive sermons and speeches that can be delivered or shared are not those sermons or speeches that we articulate. The most persuasive and powerful sermons are those that we live, not the ones that we speak. And the people in this room assembled here today, in the sound of my voice, you all are living the sermon. To the least of these, we know, but for the grace of God, go I. And I want to talk to you about a word. And it's interesting for those of you all who visited the unveiling of the statue near our historic courthouse of the statue of John Lewis. It's an amazing, powerful testament to an amazing American life. But you may not remember, there's only one word carved at the base of the statue. One word. So the next time you're downtown or near Decatur Square, stop by and contemplate how one word encapsulates an amazing American life. And the one word is empathy. of all the words that could have been carved or written or shared about this American hero, empathy. Empathy rises above sympathy. We can be sympathetic to people, to communities, to nations, to worlds. We can be sympathetic when families seek your help or you must intervene in their lives. Sympathy, but in order to truly be most effective, it requires us to elevate our sympathetic urges and to be empathetic. Not concerned about you, but literally to place yourself, to be you. To put yourself in the shoes of the person who's standing before your bench. Not to sympathize with your plight, but to literally see myself standing before the bar of justice, standing or sitting in the seat across from your desk. Once we rise to the level of empathy, we can then begin to mete out justice in a truly fair and effective way. We were, one day in the office, we were discussing, and because of the people in this room, we were discussing the large number of derelict, dilapidated properties around DeKalb County, Judge. And we had all the lawyers and all the smart people were there, and we were going through the various laws that protect private property and dictate how we go about mitigating, ameliorating these properties that create dangerous solutions and disease and crime and despair. And there were 1,000 reasons why we couldn't do more until a question was raised. What if that house was sitting next door to your mother's house? And if so, what would you want the CEO of DeKalb County to do about it? What if that child was not this child from over here or there, but what if he or she was literally your child? And oftentimes we want justice for other children, but we want mercy for ours. Not justice, but mercy. We want fairness for others, but mercy for ourselves. So all I ask you to do as you go forth from this place, put yourself. When I think about it, Judge, when I think about the counselor mentioned we distribute food, I've sat in the defects office with my mother. I've sat there as a child. So I would tell my defects workers, you know, be careful how you treat the little children in the defects office, because I'm standing here in the defects office, because sometimes they grow up and be the state director of defects. Be careful how you treat the little children. Sometimes they grow up and they become the chief judge of the state court or the chief judge of the superior court. They become a judge. They become lawyers and doctors. They become CEOs of major counties. So, keep doing what you're doing. Keep living the sermons. Keep fighting the fight. And do not grow weary. And do not get tired. And do not give up. And know that you are special when someone or something calls you to stand in the gap. The true blessing of having been the CEO of DeKalb County, it would have been okay, but the true blessing was that I was CEO during the greatest human health crisis in a century. Because then you had opportunity. That's when leadership is defined. That's when leadership is evaluated. That's when your empathy is really brought into question. That's when you can weigh your commitment. So keep doing what you're doing. I love you, and I appreciate you, and God bless you. And I know that DeKalb is in good hands because DeKalb is in your hands. Thank you so much.
Thank you, CEO Thurman. Thank you for those inspiring words. Thank you for your commitment to this symposium every year and for your service to DeKalb County.
And I will genuflect to the judge because I might be practicing law in a few more. So, no fire. Y'all know that word. It works.
Okay. Okay, before I get to the panel of judges behind me, let me say we do have representatives here today from DVHDD. Brenda Woodard, General Counsel, and Ashley Thompson, Associate General Counsel. They were kind enough to talk to me at lunch, and just wanted all of you to know they're here. They're willing to answer your questions. They'll be in the back when this is over, and they also said don't forget to go to their website. Okay, now panel 3. The intersection of mental illness with misdemeanor crimes, felony crimes, and suicide. The moderator for this panel is Judge Tara Riddle, and she is the Associate Judge in the DeKalb County Probate Court. Please join me in welcoming Judge Riddle and Panel 3.
Hello, good afternoon. Hello, good afternoon. I'm going to go ahead and let the rest of our panel of amazing women go ahead and introduce themselves to you.
Hi, I'm Sherry Moore. I am the probate judge for Jackson County. I am about to start my 4th term in January, and I am also the founder of the Jackson County Mental Health Task Force.
Good afternoon. My name is Shondina Morris. I serve as one of 10 Superior Court judges here in DeKalb County. I also serve as the State Bar of Georgia's Suicide Awareness and Prevention Chair, as well as the Vice Chair of our newly formed and approved from the Georgia Supreme Court, the Center of Lawyer Wellbeing. And I must just go ahead and say that I am a proud lifelong DeKalb resident and University of Georgia, Albany State, and Mercer. So go Dogs, go Rams, and go Bears.
One thing you forgot, wellness court.
Yeah, well, I was going to get into that.
Okay. So I am Letitia Deere Jackson. I am another one of the 10 Superior Court judges here in DeKalb County. I am a proud graduate of Spelman College, Georgia State Law School. I presided for 2.5 years over our drug court track 1, which is our high need, high risk. And right now I am like the backup quarterback for our drug courts, both tracks, as well as our wellness court.
All right. Good afternoon. I am Rethelia Stroud, and I preside over the DeKalb County Magistrate Court's Misdemeanor Mental Health Court. My chief, Judge Beryl Anderson, is out here in the audience as well, and I presided over that court for about 13 years now. I am a proud DeKalb County native as well, and University of Georgia graduate, go Dogs, absolutely, and Georgia State University Law School graduate.
So that was a great segue because my first question is to you, Judge Stroud. Okay. So you are the judge of the Misdemeanor Accountability Court in DeKalb County, which I think is a pretty groundbreaking court. So can you describe the program to everyone and what you are looking for in participants and how the program works?
Okay. Groundbreaking is a good word to describe the Misdemeanor Mental Health Court because it is the first of its kind, having been operational since 2001. But accountability courts, I didn't hear anybody say earlier, I just want to share with you what they are. I know you've heard the term, but what happened is in 2015, our legislators codified the CACJ, the Council of Accountability Court Judges, and it was established to provide effective alternatives to sentencing for nonviolent offenders, for the most part. Accountability courts, and you've heard of them, the mental health court being one, DUI courts, drug courts, and family courts are all accountability courts. And the design and the rationale for them was to help people who are suffering from other things that create the criminality in their lives. They commit a crime because of a mental illness or because of an addiction, and to hold them accountable for what they've done, but at the same time provide some kind of way to help them address the underlying issues. That's what accountability courts are, and our purpose is to hold them accountable while helping them. And so our court, the mission of our court is to decriminalize mental illness and to offer instead treatment for balance as they go through life, because I heard it said on several of our panels this morning, just the personhood of these individuals, meaningful relationships, and getting back to work and to life and avoiding hospitals. That's ultimately what they want too, is just these issues that are these social issues that are standing in the way and preventing them from doing so. So by design, and we're certified by the state of Georgia Council of Accountability Court Judges, and the other thing that means is that we get funding from the state of Georgia, and that's the good thing, the blessed thing. And what we have is a 1-year court program, and within that year, what our participants are required to do is to go to treatment, to follow the dictates of their treatment providers. We also require that they have a day structure so that they're learning different skill sets so that they can come and just participate in society just like the others of us. And with treatment, they can do that. They have to go to appointments, and we do hold them accountable through case management. They are required to have a day structure. They have to be doing something constructive and productive, like work or school or any number of things. And I want to say too at this point that mental illness, of course, is not a respecter of persons. So through our court, we've had a lot of different people. As our CEO was saying, we've had doctors, we've had lawyers, we've had law students, we've had college students. We have everyday people that come to this court because it's just not a respecter of any person. So, and while they're here, they are in court at least at a minimum of once a month. But starting out, because we have 4 phases, they're with us every week as they get acclimated to what our expectations of them. And our expectations is that they're going to enter treatment, they're going to stay, they're going to do what they're required to do. We also offer groups through that certified funding that we get, a Thinking for a Change, to offer cognitive skill sets and those sorts of things. But I tell you what, I can go on and on about it, and I will come back and answer questions, but today we have with us a participant from our court who can tell you best in her own words what we require and how she's met those requirements, because she's also scheduled to complete our court after 1 year. Next Thursday on November 7th, she will complete our court. But I just want you to hear, and I'm yielding some of my time, Judge Riddle, yielding my time, so that she can just share with our audience.
You're fine.
Okay. She can just share with the audience what that experience looks like, what participation looks like, and what it affords to those suffering from mental illness but thrust into the criminal justice system because of that illness. If you would, this is Miss Toya Palmer, and as I said, she's been with us almost a year. She's about to complete, and she willingly came to share her story with you and her journey.
Good afternoon, everyone. Once again, I'm Toya Palmer. I've been a part of the program since November of last year. Getting into the program was kind of difficult, and once I was expressed what was required of me, I was like, "Oh, I got to go through all of this? Y'all gonna make me go through all of this?" And then I had to take a step back. Being a young woman who's never been violent, never been through anything criminal. I've suffered with depression, didn't know, had several doctors diagnosing me. I wasn't aware of what that was. No one took the time to explain until something happened tragic that landed me in jail. And when this opportunity was presented to me, I looked at it like, okay, well, this is something different. At the end of the day, this is for me. Someone is holding me accountable for something that I did. I may not have been in my full senses, but they're giving me an opportunity to be held accountable without jail time. You know, I joined the program. I met the requirements. My first 30 days is phase 1. I met with my case manager at the time. He kept me, hey, listen, you're good. You're not drinking. You're not doing it. Every week it was something that reinforced what the program was requiring me to do, to be accountable. I participate weekly in a wonderful group called Thinking for a Change. At first I was like, y'all sure about this? Y'all sure? But after taking my time and understanding the foundation of why this program was put in place, it allowed me to literally think differently. Whereas if I had those tools when this incident occurred, it may not have even occurred. It's just little small things that the resources that this court has provided to me has allowed me to change my thought process, to allow me to continue to grow and make it me versus me, because I'm not my diagnosis. You know, when I go out and I present myself to the people, you're not going to say, oh, she's bipolar, manic depressed. You're not going to see that. You're going to see someone who persevered, who's accountable for what had occurred. But because they kept me accountable, it allowed me to look within myself to find the strength to keep pushing, to make it to the end of the line. Now I'm able to share my experiences with people who are also in this type of situation that think, there's nothing else that I can do. I got to go to jail for this? Oh, I'm not even a violent person. I got to be locked up. No, there's an alternative for you. If you're serious and you're ready to stand up for yourself and be accountable, this program is a perfect program set in place for those that can actually have a second chance and make it through. So I'm extremely grateful for the opportunity to have been accepted in this program. I've learned so many things that I'm grateful and I'm able to share with other people that's in the same place that I was in. So Judge Stroud, thank you so much for this opportunity. And you guys, I'm an advocate. Misdemeanor mental health court is the way to go. Thank you so much.
Thank you so much for doing that and speaking with us all today. We really appreciate you giving your firsthand experience. Judge Stroud, did you want to follow up on that?
Just some other things that she did mention what we require. We have random screening because if our Solicitor General, who is one of our partners with this misdemeanor mental health court, has agreed to restrict their records, dismiss charges, and restrict records with successful completion. So to do that, we do challenge them. We have random screening because you can't be expected to have charges dismissed and still violating Georgia laws, and marijuana use, drug use is still in violation. So that's another part of what we require here from our participant base. So I just wanted to share that, and she did allude to that. But she did come on board, and she's done a great job. She's been a wonderful participant, and we do appreciate you too, Ms. Palmer, and I know that she'll do well. And one of the other tests too for these accountability courts is whether or not they work. And I submit to you that they do, because as I said, CACJ was codified in 2015, and now we have more than 180 of these courts in different sectors like mental health, DUI, drug, and they work. Our governor was at our last statewide conference, and he said, well, Georgia, to the tune of about $38 million savings in terms of people completing these courts and not recommitting. The recidivism is that great where they're not going back, and there's not the revolving door for Director Williams at the jail, because when they complete and they've been stabilized and balanced for more than a year, that's why it's required in our standards for misdemeanor mental health court at least a year, that they feel good about where they are. And as you could hear and you could see, see the joy of Ms. Palmer in terms of where she finds herself right now, that they tend to not come back when they've made that commitment to go forward and to be productive and constructive. So they do work, and per person that completes the court is approximately $20,000, I think, the governor. He had gotten his numbers from the CACJ. So, and he was touting these courts at the conference himself. So they do work, and I do believe in accountability courts. I really do. And we do hold them accountable. It's not a get-out-of-jail-free card, because what they're required to do when they're with us is much more than credit for time served and go back. We require a little bit, we require a lot more so that they're successful continuously. That's the goal.
Thank you. And I'm going to turn to Judge Morris. You are the judge of the Wellness Court, so in DeKalb County. So can you describe that and the similarities and differences in the accountability court we just heard about, and how your experience is with that?
Okay, yes, thank you. Good afternoon, everyone. And again, Ms. Palmer, thank you for sharing your story. So there are, as we stated before, there are 10 Superior Court judges. All of our Superior Court judges participate in our accountability courts. And there are 2 of us, myself and Judge Asha Jackson, that preside over our felony mental health court, which is also known as our wellness court. And so with us, our wellness court began operation in January of 2016 as a 2-year judicial supervised treatment alternative and sentencing program. And that is to assist felony offenders who present with severe and persistent mental illness and or co-occurring disorders. The program targets and engages moderate to high-risk recidivism and high-need service needs participants in intense outpatient treatment services as that of the DeKalb County Drug Court, or DCTV model. Our program participants also present with an extensive history of noncompliance with medication and treatment in the community, and in addition to multiple risk factors such as significant criminal histories, housing issues, and various other issues. So while in the program, the participants do have an opportunity to learn coping skills and strategies to assist them with maintaining everyday life stressors while taking prescribed medication. Now, what is unique about our DeKalb County Wellness Court that is different from other programs and program models around the state is that it offers in-house services, including psychiatric care. Our participants see a psychiatrist a minimum of once per month and are also provided with assistance with all prescribed medication at no cost. And we also provide housing if they are unable or do not have those resources. I am very happy to say that we are currently at our capacity for our wellness caseload, our wellness court caseload, and we continue to receive referrals. And this continued influx of referrals indicates a need for our program to expand so we can serve more individuals. And I can share, as having presided over our wellness court for the last several years, it is just truly rewarding to see our participants grow and successfully complete the program. And similar to with the misdemeanor mental health court, upon completion, successful completion of the program, then our participants' charges are dismissed. So it is a great program, and we just encourage you all to come out and see it. And it's just been it's had a significant impact on our community.
And I know some people are interested in the answer to this question. What type of felonies are eligible for your court?
So in terms of the various felonies that the individuals have committed, they range from theft by shoplifting, and some of the more serious, the more heinous, obviously anything such as murder or aggravated child molestations, they would not be eligible for the programs. But they're generally the low to moderate felonies that are accepted into the program. individuals that are accepted into the programs. In some circumstances, individuals who have been charged with aggravated assault, depending upon the nature of that, we will make exceptions for, but it is a team approach, so we meet with all of the counselors, the teams, to make a determination if those certain specific charges will be acceptable into the program.
Okay, thank you for clarifying that. And I want to turn to you, Judge Jackson, about how do you see the criminality and mental health intersect in your court and your criminal cases?
So to give you just some statistics, 64% of jail inmates have a reported mental health concern, and I stress reported. 54% of our state prisoners. What we also see in Superior Court and sometimes also in our misdemeanor courts are that we're having people that are coming from DOC custody or from state custody to the jails to handle charges. So there's also probably more than 64% that we're seeing. A lot of times what I have seen as a chief judge traveling across the state, just interacting with different judges and judicial centers, I have learned that DeKalb never fails me, and it's always amazing. And what I mean by that is here in our county, every single class of court that we have has either an accountability court that addresses mental health or has substantive community partnerships and educational programs. So in DeKalb, we really are doing what we're saying, right? We are showing that mental health is important, and we are working and exploring ways collectively as well as individual courts to ensure that we are making sure that having a mental health diagnosis that is reported is not criminal. And so what are some of the things that we're doing is, in addition to the wellness court that we have in Superior Court, we have 2 other courts. We have 2 tracks of our drug court. And in that, what we're finding out is a lot of times people have dual diagnosis. We also have a veterans treatment court, and we also recognize that although it's specified for veterans and their partnership with the VA, that there's also dual diagnosis. So it's not maybe as intense as some of the services that are getting solely from the wellness court, but we are still working from that. What we also find out is that there are times where people are on bond, or they may be incarcerated, but what we're finding out is that there may be some mental health concerns that the attorney has identified. And so from there, then what we're doing is on the back end, getting evaluations and treatment as conditions of probation and having early termination to make sure that we can identify that. I just learned something new, and I know Director Martin from the jail is here, and you heard from him earlier, but after people are convicted of serious violent felonies and serious felonies, they are asked if they want to speak to a mental health provider. So that is a way that we're doing in DeKalb to make sure that we are getting ahead of things. There might not be a diagnosis, but if you're facing significant time, and making sure that there are resources in place on the front end are some of the things that we're doing here in the courts to ensure that people are, I guess, again, just to say it, that even though you have a criminal charge, to make sure that you don't feel like you're a criminal. All of the programs that we put in place, whether they're formal of our science-based or whether they are through your probated sentence, are to ensure that we get more people like Ms. Palmer, people who have willingly accepted themselves into the program. Where we want to do is get them back where they can have charges dismissed, as well as continue to be productive citizens in the society.
Okay, thank you. And for all 3 of you that run an accountability court, what would you say is the marker of success? What type of individual and what traits do they have or possess that makes them successful in the program? And what support systems, could they utilize to be successful?
I'll start. Some might say a success is saying a graduation rate. I don't necessarily think that that's it is an indicator, but it's not the indicator. Overall, in our superior courts, out of all of them, we have a 58% graduation rate over 3 years. Our wellness court has one of the highest at 60%, and our veterans have 71%. But what makes it a success is when you have people that buy into the model. They accepted it, and you can measure the change because you saw how they were when they came in, and they might have been in a decompensated state. And then you see them where you're having to encourage them to take their medication, to have family relationships, or they might not have them, but as they're progressing through the program, then you see that they're having the familial contact. They are actually working. They are able to change some of their thinking. They are taking their medication as they need on their own, and they have steadily progressed in a positive way. That, to me, is a success, whether they graduate sometimes or not.
And I would say, for me, it is seeing the participants, as Chief Judge Dear Jackson stated, but when they first come into the program and they have this look on their face of despair, and then as they go through the program and they're constantly communicating more, and you're seeing this shell change and just kind of grow and become vibrant. But what it is really for me is it's not so much the graduation, but it is seeing through this 2-year process the person when they come out and they are smiling when they are engaging with you, and they're telling you about, Judge, I love my job. I have been promoted to a manager, and not only have I been promoted, but everything's going well with my family, and I'm participating in the activities, and my children are engaging me, and you just see how their life has just changed, and they're excited about taking the medication, and they're just excited about all of the various opportunities. So that's when you know it's a success.
For me, it is the buy-in, and I think it was Judge Harris that set it up here earlier. I took a few notes. Is that when a participant comes in, as you said, and they volunteer, because it is a voluntary program. They have to agree to be there, and they come, but they're reluctant, and they're fighting you all the way. And it's just so interesting because I've been around and seen it enough now to know, okay, it's just a matter of time. We just gotta work with them. But when they start to buy in and trust us, when they start to really believe that we really do want them to succeed and we're going to help them succeed, but they have to do the work. When you start to see that change comes, and it is very, very encouraging to us. And I tell our participants often we need to be encouraged too, because it's a difficult work. Make no mistake about it. Everybody can't do it. Everybody doesn't do it because it's not easy. And recidivism is the other test for the success of any program. And we were evaluated several years ago. We'll do another evaluation, Judge. We'll do another evaluation soon just to see how some other things that we've implemented within our court are working to the benefit of our participants. And that really is a test in terms of the success when you don't see, when Director Williams doesn't see the revolving door. The former director over there once said that in a given year they had 45,000 mental health arrests just at the DeKalb County Jail. So when you don't see that revolving door continue to revolve to the extent that it does, then that's also a test to success for any program.
That's great. And I want to address just a minute about probate courts. And obviously we are civil courts. We don't do criminal. But as Judge Wolk said earlier, we do see some of the same folks that go through accountability courts. And hopefully we can have some of the issues addressed before they get a criminal charge. So one of the ways we see that is in the OTA process that some of the other panels talked about before, the orders to apprehend. Some families will come in to try to get an OTA of their loved one to get them evaluated before that arrest happens, when they are, out in the world having behaviors that may cause them to, get arrested. We also see pretty frequently in our guardianship cases, families will file guardianships when they are sometimes concerned that their loved one is, again, doing some behaviors that may draw an arrest, and want to have that guardianship in place so they can explain to law enforcement or, criminal defense attorneys, prosecutors that this person has already been declared incapacitated. We also get a lot of guardianships after someone has drawn charges and has been arrested in order to become that person's guardian so that they can help them, find a criminal defense attorney, manage their defense, show up for court. We see several of those a year in Cobb, and I'm sure you all do as well. We even have some criminal defense attorneys who are, advising the families to go ahead and get the guardianship at that point to help them in those negotiations and maybe, have them become eligible for a program or have a conditional release or even drop the charges. So that's where we're seeing those cases in probate court. Even though we are a civil court, we see that juxtaposition of criminality as well. Before we turn on to our next topic, is there anything else you all want to address about the accountability courts? Okay. If we have extra time, I have a few more questions about that, but I want to move on to our next topic, which is mental illness and suicide. So I'm going to turn first to Judge Moore, who is doing some amazing things in Jackson County with suicide prevention and awareness. So can you tell us about what is going on in Jackson County?
Sure. A few years ago, in some of our probate court training, I learned about, or we all learned about, a community mental health collaborative that was established in Carroll County, and I was very interested in that. Jackson County is a rural county with limited resources, although now we're still what I would consider rural, and we are definitely still have limited resources, but we are one of the fastest growing counties in the state. And so we don't have a hospital in the county. The only medical hospital closed since I've been in office. So we send people out of our county for OTAs and for treatment. But there's always been a need. I have 22 years of experience in probate court. Before I was elected, I was the chief clerk in the Clark County Probate Court. So I've been dealing with probate court mental health for a long time. And I've heard all kinds of stories over the years of examples of people who are mentally ill and the things that their families or neighbors, whoever the individuals are who are coming to the probate court to give the testimony. It's almost unbelievable sometimes the stories of what they are experiencing with their loved one. And so, I've been hearing that for a long time. And then I found myself with a very personal reason for wanting to make a difference and wanting to make things better. Our son was diagnosed as being bipolar 2 when he was 14. He was just before his 15th birthday. And interestingly enough, the Friday night before my runoff election, we took him down to Athens to Athens Regional Hospital and had him we spent the night with him in the psych ward. He was suicidal. And we stayed all night with him and watched him be strapped on a gurney in a straitjacket and taken to Summit Ridge the next morning. So I had planned to be out campaigning that weekend, and I stayed home, my husband and I, and just were basket cases. And so it got real personal real quick for me. And he was discharged from the hospital a couple of days after I won the election. I actually called to the hospital that night to beg the charge nurse to just go let him know that I had won because he had campaigned with me this whole time. So we battled with him for 5 years, and he took his meds. We went to doctors, we went to treatment. We did everything that we thought we could, and he managed to graduate by the skin of his teeth. He was really smart and wanted to be a lawyer, and I can assure you he was great at arguing, so I thought he'd be a great lawyer. But at 19, he just couldn't fight any longer, and Caleb died by suicide, and that was 7 years ago. So I knew immediately that I had to do something to help other families, to help my county. I wanted, first and foremost, to prevent any other parent from going through the hell that we experienced. but I knew there was a need to help reduce the stigma, to increase services, and to bring awareness to mental illness. There's still a lot of stigma. We've made great strides, I think, over the years, probably in the last 10 years with reducing stigma, and it's more talked about, but people still do not want to admit that they have a loved one that is mentally ill. They don't want to admit that their child is mentally ill. I founded the Jackson County Mental Health Task Force. We got started about a year ago in partnership with Family Connection, and Family Connection group pooled their resources, and I had people that had indicated an interest in starting and participating in that. And we have judges, community service providers, private providers, school personnel, law enforcement, domestic abuse treatment center in our county, private citizens, Boys and Girls Club, just a great people from all walks of life and all areas and agencies that are participating in this, and we meet once a month. One of the things that we have done is we have had a group that formed that was interested in forming a local NAMI affiliate, and so we are an emerging affiliate, and we are working on getting that up and running. And we created a law enforcement mental health task force that kind of was a side group out of our main group, and we created what we called mental health push cards. And one of the things that I've realized over the years is that very often, as you all are well aware, law enforcement gets the call to come out and deal with people who has a family member in crisis. And through the lens of the chaos that they're experiencing, they're not able to hear very little of probably of what they're being told. Are they receiving, and is it registering with them? And so law enforcement may say, call GCAL, or you can call the community service provider, or here's some resources, or you can go see probate court. That's their favorite one. But the families aren't remembering that, and they can't really process it all. And so we created these cards, and they were paid for actually out of opioid funds through the opioid settlement, and they're long, thin cards, and they've just got a list of substance abuse and mental health resources on the front and back. And we have made them available to the different municipalities. We have 9 municipalities in Jackson County, and so we've made them available to all of those law enforcement offices, and then, of course, the Sheriff's Office, EMS. They're in various courts or community buildings, government buildings, but it is a resource that the law enforcement or first responders can hand out when they go out and get that call to go out to the public, to a home that's in crisis. They have something they can give them, and we've gotten really good feedback from those.
What advice would you give to another rural county who might want to develop a similar type task force or resources for the community?
Just do it. I partnered, as I mentioned earlier, with Family Connection. She had a lot more resources than I did and knew a lot of people. One thing that I thought that I've really gotten out of it, and we've talked about it as a group, we've all benefited from knowing what resources are available. I don't really have much experience with the schools other than by being a mother crying in the counselor's office with my child, trying to get my child graduated. And we're a unique county. We have 3 school systems in our county, 3 public school systems, 2 city and 1 county. So we unenrolled him from city and then put him in county. So I've sat through two of those school districts, trying to figure out how to navigate through getting him the services that he needs and get him graduated. but other than that, I didn't really know a whole lot about the school districts. They didn't know a whole lot about the courts necessarily. And so it's been a great resource for all of us to learn what each other does and what's available. And so, and if you build it, they will come. I mean, you know, and some people fall off and others join, but it's been a great project for the county.
All right, thank you for that. Judge Morris, you are the chair of the State Bar Committee on Suicide Prevention and Awareness, I think is the name, right?
Yes.
Can you talk about your role in that and what the State Bar is doing for suicide prevention?
Okay, thank you. So I will start by sharing some facts with you all. These are actually very alarming facts.
Yes.
So less than 2 years ago, 1.6 million people in the United States attempted suicide. And exactly 49,476 people, almost 50,000 people, died by suicide in the United States. So I became involved in the State Bar of Georgia's Suicide Awareness and Prevention Committee because of my personal experiences. And I will share that suicide is preventable. So back in about 2001, about 6 weeks before my wedding, my father was in a mental health crisis. And that was unknown to anyone in my family. And so my mother was not doing very well with accepting what was going on with my father. It came completely out of the blue. So I had to take some responsibility, and ultimately I had to have my father involuntarily committed. And so as my father was receiving treatment, when he finally came home, it was probably about a little bit less than a week, my father said to me, you know, now everybody thinks that I'm crazy. And I said, well, no, we don't think that. We just know that you needed to get some help and some treatment. So shortly thereafter, I was preparing for a wedding, was really excited about it. And one morning, I was actually a young prosecutor. I was working at the Fulton County District Attorney's Office, and during that time, we had Thursday morning meetings where we would announce what was going on with our various cases. So that morning, my father came upstairs because I was still living with my parents, saving for the wedding and everything. And my father came upstairs and he said, hey, I prepared breakfast and I just wanted to know if you wanted to eat with me. And I said, well, I'm running late for this meeting. I'm not going to be able to meet with you and have breakfast, but I'll see you later on. And as I was rushing out the door, I did not realize the disappointment in my father's face. But as I was presenting at that Thursday morning meeting, my father went upstairs to my bedroom and he ended his life. And so that had a significant impact, to say the least, on me and my family, because while we were processing all of that, my family was telling me, don't tell people that your father died by suicide. Tell them it was a heart attack. Tell them it was anything but that. And so as I was trying to hide what had occurred with my father and just with my life, it caused me to have a substantial amount of physical and mental issues. And so I was constantly working around the clock. I was receiving numerous awards and being successful in my career, but I wasn't taking care of myself. So ultimately, when my husband and I finally wed, after a few years, and as we were trying to start our family, I was still having problems. So I had just given birth to our son, and I wasn't able to sleep. I wasn't able to focus. I wasn't able to concentrate. And I was having a whole host of health issues. as such, my OBGYN said, I think you need to go talk to somebody. I think you need to see a psychiatrist. And so I was thinking, I don't know why I need to see a psychiatrist, but okay. And as I went to see the psychiatrist and I shared what was going on in my life, the psychiatrist said, well, I think that you are suffering from postpartum depression, post-traumatic stress depression, anxiety, a whole host of things. And as lawyers, as we often do, I said, well, doctor, with all due respect, I totally disagree with you. And I didn't go back. But those medical challenges that I was having were still there. And so finally, I spoke with someone, actually with the State Bar of Georgia, and they said, I think it might help if you share your story and your experiences. It might help some other people. And I said, well, nobody's going to want to hear this. And so I went and I shared probably with a group of approximately 200 lawyers what happened with my father and my experiences. And at the end of the presentation, I remember the room being completely silent. And in my mind, I was thinking, this is why I don't share, because everyone thinks that I'm not going to be a good lawyer. And after that, there were so many people that reached out and shared about family members that had mental health challenges, as well as some of them. And so that is why I became involved with the State Bar of Georgia's Suicide Awareness and Prevention Committee. And that is why I go around and share with people that we have to take care of ourselves. And so I encourage therapy and talking to people and normalizing the conversation, because we can save lives by doing that.
Can you address a little bit what resources the State Bar provides? Because it's, I think, all of our understanding that lawyers have fairly high rates of suicide compared to some other professions, and there are some resources out there. So can you address those?
So for all of those attorneys and judges that are present and also present via Zoom, the State Bar of Georgia offers Use Your 6, and it is 6 free counseling sessions for members of the bar, in which, whether you would like to talk to a therapist that is recommended, and it is completely confidential, you can speak to a therapist, psychologist, psychiatrist, or if you have your own, it is something that is a part of your bar membership. And that counseling includes anything from stress management, anxiety, if you're having issues within your family, whether it's marriage, whether it's children, whatever it may be, you can speak to a licensed therapist and counselor, and it is, once again, completely confidential. In addition to that, we have Lawyers Assistance Program, where you have also peer-to-peer, in which it assists members of the bar where we can assist each other. So those are just a few resources that we have. As I stated earlier, we now have our Center for Lawyer Wellbeing, which was approved by our Georgia Supreme Court justices, and we're really excited about that because there are so many resources that we have, and it is in one centralized location, so you can find out about all of the resources that we offer with the State Bar of Georgia.
And I think some counties, like in DeKalb County, we have a local Lawyers Helping Lawyers section, not really a section, but a committee in our bar association. So check with your county as well and see if you also have a local one in addition to the State Bar. Our local one is great, and as judges, it's great because if we are concerned about a lawyer, for example, in our community, we can kind of reach out to them and say, will you all check on this person? And other members of the bar can do that as well, and they'll step in and help with cases or, whatever, not medical advice, but, work advice, help with cases, help with time management, urging that person to maybe go seek some help. So that's a good resources for you as well. Is there anything else? Actually, I have a question more about the state bar. A few years ago, the state bar made it mandatory for everyone to do, I think at every CLE that year, we had to watch a video on suicide prevention. Do you remember that? And it's been quite a while, I think. Do you know if there's any plans to make that a regular thing or make that more, again, a mandatory viewing amongst the state CLEs?
So we are in the process of continuing that. I believe that was during President Robin Fraser Clark's year, as well as transitioning to former State Bar President Bob Kaufman and Ken Hodges. And so what we are trying to do is coordinate with CCLC to incorporate it with all of the CLEs, the mandatory CLEs, to bring it back. Our lawyers, as often lawyers do, they did not necessarily want that to be mandatory, but we are now in the process of just having 1 to 2 hours, continuing legal education hours that is committed to that and wellness and well-being. I would also like to just share with everyone, and this is regardless of whether you are a lawyer, a judge, but just anyone. If you know someone or if you feel that someone might be having some issues or suicidal thoughts or ideations, what the research shows is that just ask them. Ask someone, hey, you seem like you're a little bit distant lately, or you just don't seem to be yourself. Are you okay? And you can have those conversations with people. And oftentimes we feel like, oh, I don't want to ask because if they are, that might cause them to do something. Well, all of the research shows just ask, and most people are honest with you. And if that person in that conversation, if that person has indicated that they have a plan, such as, well, yeah, I'm kind of down, I'm kind of depressed. I was thinking about maybe going to the 7th floor of my building, and I've just been thinking about how that would look if I did X, Y, and Z. Then that person has an identified plan, and what you should do if something like that happens, you need to tell the person, I'm very, very concerned about you. As such, I want you to stay on the phone with me, or I want you to stay with me, and I am going to call. And whether that is where we have the mention of text 988, or if you're going to call a crisis number, or that person's psychologist or counselor or whomever, but let them know what you're going to do. If that person does not have what you believe to be an identifiable plan, just talk to them and encourage them to seek medical advice, and just talk to them until you feel comfortable with them, but don't be fearful to have that conversation.
And I think part of the challenge is the stigma. This is a question for the whole panel. What do you all think can continue to be done to get closer to elimination of the stigma of talking about suicide?
What I appreciated earlier was the sheriff owning the fact that it's in her family. And I say to people often that if we're honest, if every last one of us in here is honest with ourselves, we could admit to ourselves that either we know someone, love someone, or we know somebody who is suffering or has suffered with a serious mental illness. And I think we have to be honest, and we have to speak our truth, just as Judge just did here with telling the story of her father and herself. That's very, very real, and it means something to people. If she can admit that, then perhaps I can admit that. And that's part of it, because sometimes families won't admit it. I have a girlfriend whose daughter suffered for years, and with the work that I do, I could not convince her to get help for her and to own the fact that she is never going to be the one to take over the business. She can't. But still today, she is still trying to push that with her daughter. And when she has a breakdown and she's back in a facility, she still can't own it. And so I think for those of us to just start to speak our truth, tell the truth, about it.
I would agree. I would say transparency and education. And the education doesn't have to be formal. It could be, just as Judge Morris just said, it's preventable. And then she told you how it's preventable. What are the things that you can do? But I always say asking for help is never a sign of weakness. It's a sign of strength. And so trying to help ingrain that into people to know that it's okay. If we're all going through it, it knows no person, it knows no bound. And this is what you do if it is you. And if it is someone that you know, this is what you do.
I would just say keep talking about it, which is what we've all just said. There are very few people that have not been impacted by mental illness in some form or fashion. I would hazard to say probably no one in today's society. We all know someone. It's either ourselves, our family member, a friend, but somehow we've been impacted, and unfortunately, more and more of us are being impacted by suicide. That was something, I will tell you, that my husband and I, when we married 31 years ago, we each had a very, very distant family member on both sides of our family that we had heard died by suicide. And then we lost our son, and within a few years, we've lost another distant family member and 3 of our own friends. So, we've all been impacted.
I think as far as the mental health stigma goes, I see it getting a little bit better. If you ever drive a car full of middle school or high schoolers around these days, they are much freer than our, generations in talking about that. And you'll have, the kids in the back, oh, I'm on Zoloft. What are you on? And I have social anxiety. And I think I just got diagnosed with depression. So they are talking about it, which to me is great. And I feel as parents, we need to let those discussions happen. And it's a little jarring sometimes, but it's a breath of fresh air, because I think, when I was in high school, you just didn't talk about that. And I'm sure people had, the same level of mental health issues, but it was taboo. So that is nice. And I think we just have a lot more work to do to keep going with that. So we have actually a lot more time. So I want to ask you all a question back to the accountability courts for a moment. What I'm curious about, is there a story about a participant that you think is either the most impactful, the biggest change, your favorite participant that you thought would be helpful to share with the group to show the success and what we can accomplish in the mental health arena?
Oh, wow. I have several. Well, Ms. Palmer is one, but one of my favorites is we had a young man a few years ago that came to our court because he lived with his mother, who oftentimes had male friends that would come in, and he would be mistreated or beat up by him or whatever, but he ended up committing a misdemeanor here in our county and came through our court. Well, while he was here, he went into treatment. He got the treatment he needed. He took advantage of the groups that we offer, and he just got so much better and so inspired and so encouraged because his girlfriend's mother took him in, and they were willing to help and support him. He left our court and he joined the Navy. The Navy accepted him. And occasionally he would let us know how he was doing and where he was. And that was just a very, very good story for me, because I just saw where his life could have gone, but where he chose for it not to go with the help that we were able to give him in our court. So he's one of my favorite stories. I like to talk about him.
I will say one of mine is a gentleman. He came in, never had a driver's license, never had a bank account. And by the time that he graduated, he had been promoted in his job, had his bank account, and actually was able to buy a car, his dream car that he wanted. It was like an older, I won't call it antique, but it was just an older version of a Mercedes that he had, for his whole life, he wanted. And the fact that he was able to do that, have the pride, and is still doing well. He works in the downtown Decatur area, and so sometimes I've seen him. But just to know that you've gone from not having a lot or having anything and being able to take all the tools and the resources that you have and fulfill your dreams?
Let's see, one of the participants that comes to mind with our wellness court, he graduated about a year and a half ago. When he first came into the program, he was very resistant. He was often failing his drug screens. He would often test positive for marijuana. And then as the program went on and he was started participating in the group therapy sessions as well as his own individual counseling sessions, and even during our court proceedings, he started to share about his dreams and his goals. And his dream was to have his own business where he was into the organic vegetables and fruits and things of that nature. And so as he progressed through the program, the job in which he was working, he went from just working as a regular cashier to he advanced, and then he became a manager. He led a group of about 10 individuals, and then from there, he successfully completed the program. He started his own business, and he actually left the state of Georgia. He went back to his hometown, but he is still doing very well. He comes back, he checks in, and so that is one of our very successful programs and participants that we had.
And how flexible are you all with the participants in the program? I know it seems like the ones that we have in Cobb, they're, not everybody follows the same trajectory, and some people need a little extra time. So tell me how you all handle that, because everyone is different, I'm sure, and has different needs.
Our case management plans are individualized, so that's how we treat them. When they come in, although we have 4 phases, phase 1 is typically 30 days, but it might not be for another individual. We have somebody that's there now that we're trying to encourage and inspire who's been there for about 60 days because he just can't seem to acclimate. But we're trying to give him time, and that's what we're doing. So I think you just have to, just put the resources with them that they need, because his is just not being able to get these screens right and being in place like he needs to be. But he's a young man, and so we expect some of that. It's gone on for a while now, so we are, just kind of focusing on trying to get him to the next stage. So you just have to because they're individuals, they really are, and you have to address the personhood. I heard that word used, and I liked it, so I'm going to take that one. You just have to do that with them. Now, Ms. Palmer, because she's not old, she's a young lady, but she's a little more mature than some of our participants, and it's amazing how they've watched her and how she's able to inspire them and to speak to them, sometimes in group in a way that we didn't see or were not. So they watch each other, they watch us to know if they can trust us. And the camaraderie that we see, that I'm starting to see develop amongst the participants is just astonishing. And sometimes they're able to encourage and inspire, but we just have to take them where they are and work with them where they are.
Accountability courts, because they're science-based, there's funding attached to them, it's structured. But within that structure, there's some flexibility. So I kind of like to say, if I asked everyone to take a piece of paper out and a pen and draw a dog, everyone's dog is going to look different, but you have the instructions and the parameters to draw a dog. And so we have 5 phases, and sometimes it takes a little bit longer for you to get through phase 1. Sometimes you move right on through. But what we do is, as Judge Morris mentioned it earlier, it's a team. The counselors, the case managers, the prosecutor, the public defender. You have all of these different people. You have your psychiatrist when you need it that come in, and the judge, and they are collectively that person's cheerleader, right? So each person has their own cheerleading group to make sure that we are getting them where they need to be. And sometimes when they fumble and they have to take a step back, they may be in this phase, but in moral recognition therapy, or what's called MRT, they might be on step 5, but something has happened and now they have to come back to step 1. So they're going through it again, but the goal is still to operate within the structure that has been defined and provided by CACJ and our federal funding.
I like that word fumble. I'm taking hers too.
That's it. And in addition to that, I think in terms of from the judges that are presiding over the matters on the bench, I had the opportunity to attend a mindfulness for judges with our Chief Magistrate Judge, Judge Burl Anderson, who is present here today. And one of the things that I think makes this so successful, our accountability course, is as judges, you are very mindful with the participants. So you can spend that time one-on-one and being mindful, being present, addressing their individual issues. And you know, if something is going well for them, you congratulate them. And if something is not, you can have that conversation with them. And it's just the two of you having that conversation. Like one of our participants a couple of weeks ago, unfortunately, lost his daughter to an overdose. And so he's in our wellness court. But just having that moment, that opportunity to be present with him, and he knowing that he has the support of the team, but also the judge, and it just helps a lot. So those are some of the things that you can do that individualizes it and makes them know that not only are you there to support them through this program, but you're also there in a personal capacity as well.
And we heard some of the other panels talking about housing and how critical that was with the interplay and mental health. How does housing and housing instability play into the accountability court process? And are there resources for those individuals?
So I can talk about on the Superior Court. On Superior Court, again, and Judge Morris mentioned that we have in-house services. We literally do it all. And so we provide housing. We are the only court in the state that provides housing. So we have contracts with different houses, and there are rules to those houses. So even though you are living there as a participant, no one that you are affiliated with can know, not even your mom. You know, and everybody knows if all else fails, you can call your mom, right? But your mail goes to a centralized place. And so what we do is we try to take all the barriers that we know are possible to just flood you with all the positive and all of the resources that you need to be successful. And so that is something that we deal with in DeKalb. Sometimes if they live out of the county, what I've also seen the courts are starting to do, and what the team will do is they are partnering and contacting whatever jurisdiction. And then they're saying, can you take this person? They're qualified here, but it might be a barrier because if they have to move here to DeKalb, they might be unstable. And so are you able to take them in Cobb, or are you able to take them because we have identified housing for them there? Sometimes if it's not an accountability court, we see them back in the courthouse. Unfortunately, because if they don't have housing and they need services, they're not reporting. And it's like anyone else, if you don't have housing, there's other things that will happen, and your priority is not necessarily reporting or staying in contact, taking your medication and those types of things. And so we see them back in court. What I can say in DeKalb, as you see, I just love DeKalb. Most of the cases are through our public defenders, and what we have seen there is they have an in-house social worker. And so they actually will work on the front end before it comes to the court to try to identify resources, whether they're programs, if there is a family member or somewhere else where they can eradicate the housing instability, so when they are released back onto probation, that they have some type of stability.
Okay.
I made this note earlier from one of the other panels, that housing is absolutely critical to accountability courts because of a surveillance issue. Because we have to know where they are, what they're doing, and what's going on with them. And if for whatever reason somebody is just not reporting, then we're going to send our post-certified officer, who is a part of our team, to just kind of go and see what's happening where they are. So they have to have housing, just because that also adds to the balance. Now, we're not able to provide housing as our Superior Court might, but what we have is a 501(c) advisory committee that also raises funds and raises money to help our court. And they will help them with rent payments sometimes as they may fall behind, with utilities payments sometimes as they may fall behind, or for deposits sometimes as they might have needs. So we do have that kind of support that grant funding cannot and is not allowed to help. And I'd like to share this story too. We had a lady that finished our court about 3 years ago. She finished our court. And she was one of the ones who came, and she was just angry to be there, but she came around and was a very, very good participant in the end. She contacted us earlier this year, contacted our coordinator, who's a different coordinator but has the same telephone number that our former coordinator had. And she told her that she was in trouble with her rent and something else, and if the court could do anything to help. Well, Connie, who's our coordinator back there, and asked me, and we contacted our 501(c), and they absolutely did. They paid her rent not once but twice to help get her out of the bond. And that's what I mean by trust. When they do believe that you care, they let certain guards down, and that's what happened with this particular lady. She had had nobody that she could count on all of her life. And so when she came to us, she was also in need of help for getting her daughter back. So our people come with a lot of other issues besides mental illness. They present with medical issues, they present with housing issues, they present with a lot of other concerns that we help them with. And because she grew to trust us before she left us, she called us back when she was in trouble again so that we could help her. And we did. Well, our 501(c) did. So shout out to them, they're great.
You asked something earlier, and something Judge Stroud just said is, what is a success? I think a success is when you can actually take the stigma out of court. So a lot of times you hear, oh, you're a judge, or oh, you're at the court, ooh, I don't ever want to go there. But when you have people who their first interaction with you is because there's been some form of incarceration, that's never a pleasant situation. But when they can come back and know that they can trust you, and you can be a safe space for them, and that the court is more welcoming and not critical, I think that is a success overall, because they'll share. That participant is gonna share what happened in some kind of way of, I was in crisis, right? I needed help. And the courts, the same people that I had to come to because I was in crisis before, are helping me, but in a different crisis. I think that is a true success of when you can partner the community and the courts and take away that stigma.
And asking for help.
And asking for help, or as we say, communicating your needs in accountability courts.
So both of you also mentioned funding. Can you describe how all three of the courts are funded? I know it's probably a long conversation, but just briefly. And also, I'm curious, Judge Jackson, how the housing piece particularly is funded, since that seems to be a rare and special thing in your court.
So real quick, DeKalb County, State of Georgia, federal government. And so there's a lot of grants, as you mentioned, that you're able to get through CACJ, which is a Council of Accountability Court Judges. They have a structured program, and they also provide funding that comes. And DeKalb County invests back in the courts, and so DeKalb County gives that. We have the partnerships for the housing that goes. You can have subsidies, as you mentioned. Sometimes when they are getting appointed, they have progressed and they're looking for independent housing. Sometimes there is assistance that will come in as well with different partners. But that's the easy way to say it, is the 3 levels of government.
That's the short and dirty.
And as far as referring people into the program, which I think would be of interest to both the lawyers and the non-lawyers in the room, are you getting most referrals from the public defenders, criminal defense attorneys, or are there other avenues into accountability courts?
It's a combination. So you have to be legally approved and clinically approved. before you can even say, I approve and I want to do this. And so the way that it happens in Superior Court is, even at the early stages, the prosecutors and the public defenders have worked in tangent to see if they can identify people. There are people who have called the prosecutor's office or told the defense attorney, my family member needs help. What are the options? And they're bringing it forth. And then sometimes there's nothing better than good old-fashioned word of mouth. Inside the jail, they come and say, I think they said they want to talk to the lady in the blazer, right? Or they want to talk to someone, and who that is it's a member of our team. Who makes rounds and does things, and they're interested in signing up because they've heard from other participants or other people going. So that's how the referrals usually work in Superior Court.
Also, our judges who handle first appearance and preliminary hearing, sometimes they make an observation at that point and they may make a referral to us. Police, we're fortunate enough with Magistrate Court that Dan had it worked out so that we get to speak to each academy of new policemen coming into our county, and we get to share with them information about the mental health courts that are here in DeKalb County. And should they go on a call and the family talks about he or she's suffering from mental illness, then to please include that in your police report, because our Assistant Solicitor General, who's a part of our interdisciplinary team, will just kind of read through those and look over those, and if there's something noticed, may make a referral or draw a referral from there. We've had participants to tell people in the community about our court, and we've got them that way as well. So just a many different ways.
Anything you wanted to add to that, Judge Morris?
No,
Okay,
that's
fine. And Judge Stroud,
Yes.
because you are, I think, a unique misdemeanor accountability court, are you seeing that movement spread throughout the state of Georgia? And have you been involved
That's a
in
great
that?
question. I've been waiting for that one. Got it right here. Okay, you know what I believe, and Dr. Coates was so great up here this morning. He did an analogy that I thought, wow, I'm going to use that one. I am fortunate enough to be a part of a federal committee on serious mental illness, and my push there, my drive there is only one of two judges on that committee, is that I think we need more misdemeanor mental health courts, because as Doctor said this morning, he talked about early psychosis, and he used some other terms that I got to get from him, that if you help people early on, then they may not grow. That illness may not grow to schizophrenia affective disorder. It might not, just kind of escalate. And I believe that sometimes if we get people early on, young people, young offenders, when they are first, they don't even know that they're suffering from mental illness. But when it happens early, and with these quality of life crimes, trespassing, and simple battery, simple assault, and we get them into treatment, and then they finally accept the fact that there is a diagnosis. They fight it because they don't like the medication, so they fight it, but ultimately they accept it, and if they get into treatment early, then that depression may not grow to bipolarism, or may not grow to the next thing or the next thing. So that's why I believe misdemeanor courts are so important, because if we have them, we can get people in them and get them in some treatment early on, and it may not grow to that aggravated assault. Or those other high crimes, and some of the others that will not even be considered for an accountability court because they're simply too violent. So I really do believe that Doctor gave me a great another analysis to kind of use, and I'm gonna have to get those terms of how he did that, but it was really wonderful, and that's my push with this federal committee, and was just there and talking about this very thing and shared it with them yet again. Now the state of Georgia, because the savings for the state is in prisons, but for our county is in the jail. If we can keep people out of our county jail. And Judge was right, our county has invested in our court for that reason, I think, too, as well, because there are some cost savings, surely, on this level. But I just think we do need more misdemeanor mental health courts. And I think right now we might have 3 in the state. There's one in Fulton. I think Clayton is trying to come online with one. And somebody else did come and observe our court, but I think we could use a few more.
Okay, and we all know that substance abuse sometimes go hand in hand with mental health because of folks self-medicating or for various other reasons. How do you all handle someone in your court that have both mental health issues and substance abuse issues?
Resources. We try, and when we can identify it, if they're not passing those drug tests and things are continuing to happen, then it's resources. We have to try and get them the resources that they need. And we do have resources. A lot of our participants actually get their treatment from Claritel. And we have a young man now, the one that is being challenged, that's going to be going to DAC. Soon, and then we're continuing, and I've asked staff to continue to look for some other resources to pile on top to help him, because this is what he's been doing for so long. He's 21 years old, and it's just going to take some time to get him to a different place of just understanding. So resources, you have to help them with the resources. And you're right, approximately 50% of people, and I think Director Williams may have spoken to this earlier, are dual diagnosed, are suffering from both, and it's because of self-medication for a long time. The voices and everything else that they're struggling with.
I wouldn't add anything other than what Judge Strauss said. It's the resources and individualizing that plan again.
Yes.
Sometimes the resources are something as simple as I'm presiding tomorrow and I was looking at some of the records or the notes from someone and they have too much free time. And so they're continuously testing positive. So one of the things that the team has asked is for them to do a 24-hour log, right? So what are you doing every hour? So that way we can help to realize and figure out where we are, so that we can move you forward and get you where, although you have both in this dual diagnosis, that we can address both of them to make you productive.
And are you seeing, do you have data or anecdotally, are you seeing rates of success with recidivism with the accountability courts? And I don't know if you just know off the top of your head what you think the success rate might be, or, like I said, anecdotally.
I don't have that data, but I can say yes. A lot of the cases, even if they're not successful, they're still flagged, and so they would return to that original judge that they were assigned to, and we're not seeing a lot of that. We see some of it, right? And some people, unfortunately, this is just not their time and where they are in life, and they just need a little bit more help, and they have to get out of their own way. But many of the people are taking the resources that they have, and we're not seeing them as much or at all.
Does anyone get a second opportunity once they can't complete the program the first time?
Yes, but that is the exception, not the rule. And it's, again, as Judge Moore said earlier on, it's a team conversation of identifying why weren't they successful and what has changed. I can think of 2 situations in the 6 years I've been on the court. I'm not saying that there's not more. That's just from my personal knowledge from presiding. And so it's more the exception than the rule.
And for folks that don't qualify for a particular accountability court, are there any other resources, and there may not be, but I wanted to throw this question out there. Let's say somebody is appearing before one of you all with criminal charges, and they don't qualify, or there is no room in the accountability courts. Are there any other resources that you all think that you can provide?
It's whatever DCS may have, and DCS is Department of Community Supervision, and so even which is felony probation, they have mental health probation officers, and so if there's other resources, but really it then becomes the onus of the defense attorney. A lot of times they will identify inpatient programs, they'll partner with Grady Act team, those types of things, those are the resources. We as the judges don't initiate it.
Right.
But it's really more so from the defense attorney standpoint. If they're a private attorney and they need the help, they always talk to the public defenders as well. But between probation and the defense attorneys are the ones that will identify those resources.
So do you mean that there are particular probation officers that are trained to deal with individuals with mental health challenges?
That's correct.
Okay.
That's all they do. Their full caseload are people who have diagnosis, and I don't know what the criteria is, but they deal with more of the high risk, high need, not someone that has that is managing their diagnosis.
Mm-hmm.
Do they have that in state court? Do they have state court probation officers that deal with mental health?
No, we use our state court probation. One is a member of our team, so I don't know who else she may have, but she helps us.
Okay, so they're probably used to dealing with mental health, but maybe not special assignments for mental health individuals. Okay. All right, I think we're nearing the end of our time, but I wanted to see if you all had any other final thoughts for the crowds today before we get to any questions. No? Okay. Yeah, so does anyone have any questions for the panel? I see someone way back there.
Good afternoon. My name is Vanessa Amos. I am with the DeKalb County Human Services Department, Office of Youth Services. Thank you all so much. A special thank you to Judge Moore and Judge Jackson for sharing your stories. It's extremely important. I don't think people really understand suicide prevention, suicide awareness. But my question is for Judge Stroud. You mentioned your 501c3 and how you have had people in your court who have families. Are there wraparound services that are provided to the children of the adults that participate in your wellness court and your mental health court?
When you say, excuse me, wraparound services, can you just be a little more specific with me? What are you asking?
Meaning more so for the families of the individual that is a part of your court. So in regards to the children, if they have family members, children that are school age, do you provide resources? I did hear Judge Morris make mention that you guys as the judges don't particularly handle that, and that it could come more from the lawyers and prosecutors in regards to sharing resources. But in regards to your 501c3 that you mentioned, is that something that is incorporated to assist with family needs as well from the mental health standpoint?
No, I cannot say that specifically it is. I mean, if we have a participant that has a specific need of some sort, they can make the request perhaps through our coordinator, and we might follow that request up with our 501c3, but per se, no, they don't.
And I would like to add to that. So generally with our accountability courts, it is focused specifically to the individual participant. But in terms of with our juvenile court, that would be probably a better question for them. They make sure that with our juvenile court, there are services, and it has a more holistic approach that addresses the child as well as the family, so that child will be supported.
Any other questions? I think people are sleepy after lunch, maybe.
Yes. I only have one question that came in on the webinar. It's asked, do we know how many people who die by suicide die by using a firearm? Does anyone have any type of statistics? That sounds like a very detailed statistic that would be hard to find, but I don't know. Is it out there?
I don't know it.
Well, you can find that information by going to the CDC. They have the statistics. I don't know if they have the statistics for this 2024 year, but if you go to the CDC's website as well as the Suicide Foundation, they list for every year in every state the the number of suicides in that state, in addition to the manner of death, and it listed whether it was whether firearms were used or another means, and it also breaks it down by age, gender, and a whole host of factors, so they can look that up on the internet and be able to obtain that information. And I will also share that this upcoming Sunday, which I believe will be November, I believe that's November 3rd, there is the Out of Darkness Walk. It is at Piedmont Park. It starts at 2 p.m., and that is a way that we all throughout the country, it is a national walk, but specifically for the Atlanta area, to bring awareness to suicide prevention. And so, as stated earlier, it impacts and affects everyone. So it's a wonderful, wonderful event. I encourage everyone, if you have time, if you like being outdoors, bring your kids, bring your pets. It's just a great event. So come walk with us.
Any other questions? I have a question. We talked about, Judge Morris, the resources for the bar and for lawyers. And I know there's been, I think at our last judges training, we had some folks come and talk about suicide prevention and awareness. Is there, do you know if there is going to be continued movement on that to talk to not only lawyers but judges as well? Because we've got several judges in the room today.
Oh, absolutely. So actually, with the Council of Superior Court Judges, we have a wellness committee which will address those issues. And so if there are judges that, or if there are judges or any judges that know judges that you think might want to talk to someone, there's the ABA, which has a hotline and which is completely confidential, just specifically for judges. As I stated before, we have the mindfulness for judges, which is with the National Judicial College, which offers each year a program to address those, and the State Bar of Georgia is working on something as well.
Anything else? All right.
Thank you. Please join me in thanking panel 3. And let's give a round of applause to all of our wonderful moderators and panelists. And a big thank you to all of you, those who came out in person, those on Zoom, for participating in the symposium this year. I hope you don't mind, CEO Thurman spoke a little shorter than we thought since he's not on the ballot, so we're going to get out a few minutes early. And that concludes the 2024 Mental Health Symposium. Thank you again for coming. See you next year, and happy Halloween.